Right, good morning, everybody. Ooh, got a bit of feedback there. How is it? Are we ready? Are we ready to go? 9 o'clock. Yeah. And are we ready to stream at the back? Are we going? Yeah, we are. Great. Right, in which case, let's kick off. So, good morning, everybody. Lovely to see you all. Lovely to see you face to face. So, welcome to the Suffolk and North East Essex ICB board meeting of the 22nd of November 2022. It's a busy agenda today. So in fact, it's a very busy agenda today. And part of my challenge, our challenge, is to also work out how to get a coffee break in the middle of it somewhere, because you'll see that there isn't one in the schedule. It's very, very tight. But I think to expect you, all of us, to go 3 hours solid without a break is probably a bit much, isn't it? So let's try and get a break somewhere around about 10:30. What that means is that the timing is already tight. It's going to be 10 minutes tighter if we're going to have a break. So if you do see me trying to accelerate you, apologies in advance, but it's because we're trying to get there. For a 12 o'clock finish. So, notification of any questions from the public. Let me first go to Simon. Simon, what have we got?
There is one question from Anthony.
Roving mic's coming for you, Simon. There you go.
Thank you very much. So there is a question from Anthony Dooley, which we've had in. Unfortunately, my connection to my Wi-Fi does not work down here, so we're hoping that somebody else might be able to have that at all.
Okay, and we'll take that.
But we can pick that up later if that's okay with the board.
We'll take that at the end if that's okay. Yeah. And anything else, Simon, or is that the only one you know of?
That is it so far.
Okay, and Joe, anything come via you? No? Okay, lovely. Thank you very much. In which case, I'm not going to go around the table with board introductions for us all, because most of you know each other already, but we do have two new members joining today for their first meeting. So Kirsten, let me welcome you, and if you'd like to press your button and introduce yourself, that would be great.
Thank you very much. Hello everyone, my name's Kirsten Alderson and I'm the new chair of the Voluntary Sector Assembly, and really delighted to have been invited here today. I do recognise quite a few people in the room because I've been part of the Suffolk system in the voluntary sector for about 10 years, 8 of which I've been CEO of Suffolk Family Carers. But I'm looking forward to meeting new North East Essex colleagues, and I'm really pleased to be part of this board, so thank you.
Lovely, thank you, Kirsten, and welcome. And I know you'll get a chance during the morning to get to know everybody. So, and Howard, it's your first meeting, even though we seem to have seen quite a bit of you. It's your first formal board meeting. Would you like to introduce yourself?
Good morning, everybody. So I'm Howard Martin. I'm the new Director of Finance for the ICB. 3 weeks in, everyone's been very gentle with me so far, which is very nice. And I've met many of you so far, and very much looking forward to meeting everyone, and very excited about this meeting, and thank you very much for
Lovely. Thank you very much and welcome. So I don't think there are any others, but somebody wave at me if it is your first meeting. Otherwise, shall we go to apologies? So Joe, what have we got? Is it just Andrew Reid? Yeah. And so apologies from Andrew Reid, the only one. Steve Feast is going to be with us, but has let us know that he's got travel issues with the train at the moment and will be here as quickly as he possibly can. Declarations of interest. Does anybody have any declarations of interest or potential conflict of interest with any agenda item, other than those of which we're aware, of course? Nick, I wonder if you would have a declaration of interest with respect to item 15, which is a fund allocation to ESNEFT, simply to note for the purpose of today.
Yes, I must admit I haven't spotted that.
That's good. I thought the declaration from Nick. Thank you very much. Any others? Any other items? Okay, so we'll take that as complete. But of course, if something occurs to you during the meeting, just flag, because it's so important that we get this recorded accurately. So, minutes of the last meeting, 27th of September 2022. There are 13 pages. I'm tempted to take them en bloc if we can, rather than turning the pages for accuracy first. Is everybody content that they are an accurate record of the last meeting? First comment from you, Paul, over to you.
My apologies, on page 8, 22 or 39, first paragraph is in the past tense, should be in the present tense, because it's essentially an assessing and will be assessing as no would be.
Will be assessing. Good
And
spot.
then,
Yeah.
And then last paragraph on there, when he talks about the NHS as 6 to 8 metrics, it's 6 domains as opposed to metrics. That's quite important.
Okay. So we'll consider those as, are you happy if we consider those as typographical errors, and we'll amend? Happy with that, thank you. Any other points of accuracy? So with those two amendments, is the board content to accept the draft minutes as a true and accurate record of the last meeting? Agreed. Done. Thank you very much. Then matters arising. There's an action log. Let's just deal with the actions on it that are noted as closed at the moment. Is everybody content with the closed, that they are closed? Maddie?
There's a final action in relation to a question that was raised at the last meeting with regard to Felixstowe. It's accurately reported that Ed had asked me to get in contact with Mr Nimney, which is in process, and I'm very much hoping to go to Felixstowe next week.
Okay, thank you very much. Otherwise, closed is complete. So on the open actions, there are 3, and do tell me, of course, if I've got this wrong from your point of view. The first one dates back some time, and it's regarding the discussion between Craig and Nick on phlebotomy data. So, any progress, Nick?
Yeah, I've had some initial meetings, still work in progress, a little bit more info I was looking for, but I hope to be finishing that very shortly.
So work in progress, and hope to be able to strike it off at the next meeting. Would that be fair? Okay, thank you very much. The next one, Paul, is against your name for the System Oversight Framework Performance Indicators, but would you be taking that in your paper? Part of the agenda. In your paper, yeah, fantastic. And then the third one, Amanda, if I could come to you for an update on the board capacity and EDI action.
Thank you very much, Chair. So following the September board meeting, a small group met at the beginning of November to progress all of the actions that we approved previously. Good progress is being made, and we are drafting specs and recruitment plans in readiness of us making a decision on the recruitment go live date. The group felt rightly that we needed to have the EDI board development session prior to us actively recruiting for a NEM, associate NEM. And in terms of the EDI board development session, we're hoping that we can still have the session in December. I'm just awaiting confirmation, which I hope to receive this morning.
Okay, thank you very much. Thanks, Amanda. So, any questions on any of those open items? Everybody happy? Is the action log, as far as from your perspective, is that complete? Does it capture all the actions that you thought ought to have been captured out of the 27th of September meeting? So we'll take that as a complete log and updated. Everybody content? All done. Thank you very much. Lovely. In which case, let's move on to item 6. First of all, a general update from Ed, and I think then Amanda will go to you for the industrial action RCN update. So Ed, all yours.
Thank you, Chair. Morning, everyone. So firstly, 2 appointments to report to the board. So Dr. Ewan Cameron has been appointed as Chief Executive of the West Suffolk Foundation Trust. Ewan is currently the Director of Strategy and Innovation at Cambridge University Hospitals. He's previously been the Chief Operating Officer there, and he's a gastroenterologist by trade and comes with a fantastic reputation. I'd also like to thank Craig Black, who has acted up for the past 15 months and has done a superb job moving the Trust forward in that time, so thank you to Craig. Secondly, very pleased to announce that Sarah Hurley, who's the Chief Dental Officer for England, has been appointed as the chair of the dental social enterprise that we're setting up at the University of Suffolk. We'll talk a bit more about that later as we're talking about dentistry, but it's a real coup for us locally to have Sarah involved with this work and to help move the dentistry agenda forward. So that's excellent. We all know that the Chancellor announced his budget last week, and there is a 3.3 billion increase in funding announced for the health service, a slight increase in capital funding, and the new hospital programme is to continue. Equally, there are funding increases for social care, including a £500 million adult social care discharge fund, which will be taken through both the local authorities and ICBs and through better care funds. There's an announcement of an independent assessment of workforce needs that will be delivered through the Department of Health and Social Care. And the Right Honourable Patricia Hewitt, who's our neighbour in Norfolk and Waveney, as chair there, will lead a review of the role of ICBs and their potential autonomy and accountability in the future. The Chancellor said that he's looking for Scandinavian quality and Singaporean efficiency in the health service, so we'll find out more about that in the coming month. Council support, but the promise, I believe, that we have locally, and as I understand it, there will be an elected leader of Suffolk County Council as part of the arrangements if it goes forward. So very exciting to see that and how it might relate to the ICB. Final few things. Obviously, a huge amount of work preparing for winter. We've put in all of our additional beds ahead of schedule, which is excellent, and we're now moving on to virtual wards. We're putting in place a system control centre from December, and we're 80% there. We have excellent full services, and we have no access to the ambulance stack, which means we can be more proactive around risk. And we've been protecting the elective programme, which continues to move forward well. And our vaccination performance has been pretty much the best in the country since we last met. But as I was chatting to Nick earlier, it still feels like we need more big ideas. The preparation is excellent, but it's not yet enough. So we're going to continue to innovate and continue to improve. Final couple of things around the CQC. So very well done to West Suffolk Foundation Trust. They received a good rating for their inpatient services recently. We've seen a good rating at Unity Healthcare surgery in Haverhill, which has been a very challenged surgery for many years, the best part of a decade. And it's fantastic to see it turn around under the leadership of Dr. David Brandon, who's also accepted a role with us as Associate Medical Director with Dr. Kelso, which is great. And in terms of mental health, the CQC are currently doing a well-led review at NSFT, and we're waiting for that to conclude. And there is a section 29A being given to EPUT following a dispatches programme on Channel 4 around some of the inpatient care there. So we're taking a particular interest in that, although the section 29A relates to facilities in South Essex. And then finally, we talked about the Clacton Community Diagnostic Centre last time. I've had a visit to it recently. It's now delivering over 2,000 tests a week, which is tremendous. But importantly, we're working with Health Education England to expand the training academy approach, which we all applauded last time, and then look at how we can roll it out into the wider system too. So some very good progress on the back of that discussion we had last time, Chair. Thank you.
Wonderful. Thanks very much, Ed. And obviously, I won't reiterate the points you made about the congratulations to the various individual people, but and also the trusts and organisations involved. But perhaps we can record appropriately in the minutes that the board supported those appointments and and look forward to further engagement and so on. Any questions for Ed? Don't see any. Shall we take Ed's report, CEO's report, as received and noted? Oh, is there one there? Sorry, Nick, I missed you.
Just a comment and an invitation, if I may, Chair, that Sir David Behan, who's the Chair of Health Education England, is visiting Clacton next Tuesday.
Oh, is he?
If any of the board would like to be part of that visit, very happy for you to join us. If you drop me an email, I'll send you the details. Thank you.
Actually, that would be really good to circulate, if you would, perhaps via Joe, Nick. And in fact, we had David Behan, a visit from David Behan at the university only, I've forgotten, I've lost track of time now, 2-3 weeks ago or whenever it was. Yeah, wonderful. Okay, thanks for that, Nick. That's great. Any other points or questions? Received and noted. Thank you very much. So, Amanda, over to you.
Thank you very much, Chair. So, industrial action. We know through the press that many trade unions are actively balloting their members at the moment with regards to industrial action. The Royal College of Nursing were first to go. They balloted and they concluded their ballot a couple of weeks ago. And they have now informed the NHS that they wish to take industrial action, the first time for many years. At this moment in time, and indeed today, we are still awaiting official notification from the Royal College of Nursing with regards to when they intend to take action. We are required to be given 14 days notice of such action, and we know that they have until probably a 6-month window in which industrial action will be taking effect from. So in the meantime, lots of activity preparing. We have weekly, we have daily conversations with region and our provider colleagues, and indeed our trade unions. So at this moment in time, whilst we await the official outcome in terms of when industrial action will take effect from, we continue to plan. And a piece of work that's actually happening within our providers is working through the emergency and non-emergency services which will be affected. Once that's been concluded, we'll be reporting that back to our trade unions for hopeful agreement, and then from there on we will plan rotas accordingly. So I think in summary, we know that the nursing union would be taking action. We're still awaiting the date, and in the meantime we continue to prepare with region and provider colleagues. Thank you, Chair.
Amanda, thank you for that update. Any comments, Nick?
Yeah, just to give assurance to the board, I mean, I know in the same at West Suffolk, having had conversations there, but certainly from an acute community perspective, there's some very, very detailed contingency planning going in. Just to give you some ideas of numbers, in terms of the likely impact, 56% of the eligible nurses at ESNEFT voted for industrial action up to and including strike. I know we don't know whether or not all those colleagues will actually take strike in that eventuality, but that gives you some idea, and then we're planning. I think the key is the agreement between ourselves and the unions around what is defined as urgent and emergency care. If we were having this conversation 3 years ago, it would be very different, but I think now that people have been waiting so long for elective care, at what point does that tip into actually the consequences of not having that operation become much more serious than a kind of an 18-week wait. So it's a bit more nuanced because of the long waits, but the relationships with the unions are fruitful and helpful, and I think, as it says in the paper, none of us would like to be here, but I think we're just taking a pragmatic approach to the planning and the contingency. Thank you, Chair.
Thank you for that, Nick. Very helpful. And I think at this point what we should... Oh, sorry, yeah, Andrew, yeah.
So just to add to the position from a medical point of view, so although the British Medical Association isn't proposing formal industrial action, they are taking action on extra contractual work at the moment through what they call a BMA rate card, which is trying to increase the amount of money that doctors are paid for extra contractual work, and also some advice for general practice on how to maintain safe working levels in general practice, which could be viewed as a soft form of industrial action. We're engaged in discussions on both those fronts, and all 4 providers that we work with are working together to ensure that patient care and safety is maintained at the same time as managing the costs associated with those demands.
Okay, again, thank you for that update, most helpful. Any further questions or points? And I think from the point of view, from the board's point of view, I asked the board, are you assured that the business continuity challenges that all our organisations in the widest possible sense are facing, that those business continuity actions are in place, not necessarily completed, of course, for the reasons colleagues have described. And Nick made a very good point about the subtlety and nuancing, which I think I saw a number of colleagues nodding to, Nick, so thank you for that. Are we assured that business continuity actions are in place and moving forward in an acceptable way? Yep. Okay. Noted. Thank you, Amanda. Thank you very much. In which case, then, let's move on to item 7, the experiences of waiting for elective care. Very apposite. I'm going to initially ask Ed to say a few words by way of introduction. Then, Andy, I think you would also like to say a few words. Then we're going to hand over to Susan and Angela, and you're going to run this item for us. And Ed, over to you.
Just really to say thank you to Health Watch and the team. This is an excellent report. It's already been to our elective care committee, and I think it's so important that we talk about patient experience at this board, and I think the report really delivers on that. So very happy to hand over to Andy to introduce it properly. Over to you, Andy.
Thanks, Ed. And just while Andy checks the microphone, let's see if...
Is it on?
Might need, probably the volume will turn up. You'll get some technical help coming, Andy. Yeah, all yours.
Thank you.
Perfect.
I won't say too much. There's only a couple of things, really. First of all, the approach that this was taken, that we took with the 3 hospitals concerned, West Suffolk, Essex, and the James Paget, was quite unique. And that collaborative approach with an independent body such as ours brought about quite a significant response from the public. And I hope you take note of the recommendations and take some actions away from the presentation today. It's important to recognise that what we're looking at here is a system approach, and it's not solely the hospital's responsibility to try and support people whilst they're waiting. The other bit that I wanted to bring up is that because of this model, I'd like you to also consider as an ICB how often we could take this approach for other evaluations and other surveys, because a collaborative approach is the best way. That's all I need to say.
Wonderful. Thanks, Andy. So, Susan, all yours.
Thank you. So I'm Susan Balaam. I'm the Research Officer for Health Watch Suffolk. I'm going to give a brief overview of the work that we've been doing, and then I'm going to hand on to Angela, who's going to talk to you about the work that's already been happening and some further work that needs to be done. So I know we're short on time, so I don't mean to go through the method and sample in any detail, but if you are interested in reading about it, then please do go onto our website. You'll find our full report there. There were just 3 things I wanted to mention, though, at this point. Firstly, as Andy said, this was taken from a national survey, and we adapted it to our local needs through co-production. We crucially had the support of the acute hospitals in helping us to promote the survey amongst patients on their waiting lists. And because of that, we got a tremendous response. We had over 1,380 people respond to our survey. Next one. So I just wanted to focus on a couple of things this morning. There's lots of findings within our report, but just a couple of things. So we found that the support currently offered to people whilst they wait for elective care does not adequately address the many ways in which their lives are impacted by those delays. So while 80% of our sample said that they had been offered support whilst they waited, only 39% felt that they had the right information. The second point was around communication. Communication was a real challenge for many of our respondents. 48% of our people said that they hadn't even been given an indication of how long they might have to wait. And for several respondents, they highlighted the fact that that not knowing had impacted on their mental health and well-being. Next slide. Before I go into the detail on those two issues, though, there was just one other thing I wanted to share, which was people's willingness to travel to access quicker care. So 71% of people said they'd be willing to travel if it meant that they would be seen sooner. Those who'd been waiting longest were most likely to say that they were willing to travel. And the graph there shows you that actually people were willing to travel quite some distance. So 27% of people said that they were willing to travel anywhere within the UK to be seen quicker. The other aspect to this, so 12% of people said that they would consider paying privately in order to be seen sooner, but for the majority of our respondents, that simply wasn't an option. And I was really struck by one quote that I read, which said, "My husband had recently had an operation which we paid for, so we can't afford my operation." And it just highlighted for me that these are whole family issues. It's not just about the individual, and that families are having to prioritise their needs. Next slide. So coming back to the issue of impact on life, the illustration on the left of the slide shows which aspects of life were most affected whilst people waited. So 76% said they experienced increased pain, 73% said their social life had been impacted, 2/3 of respondents said that their mental health, their family life and their ability to undertake household tasks have been affected. And what came through loud and clear in the data was that it's not just about one aspect of life, but multiple aspects were affected. So on average, respondents indicated that between 3 and 4 aspects of life were affected, and for 1/3 of our respondents, they said 6 or more aspects had been impacted. We then asked people what support they'd been offered whilst they wait. Again, as I said before, while 80% said they'd been offered support, only 39% felt that that was the right support. And that diagram on the right of the screen is trying to illustrate that point. So 53% of people who experienced increased pain said they'd been able to access help to manage their pain levels. But amongst those who said their mental health had been impacted by the wait, only 16% said they'd been offered any help. And those figures are even lower for social life and household chores. I just wanted to share a few quotes that we'd received from people that highlight the impact that this is having for them. So, someone who says that their pain was so great that they wish they didn't have to wake up to face it the next day. People feeling cut off from social groups, inability to work leading to financial worries and stress at home. That second from last quote, it shows, the impact on relationships. It took such a toll on my life, we ended up separating. And the thing is that some of these issues, they just don't go away once that person has had their medical treatment. These are long-term issues that carry on beyond that point. Next slide. So, as I mentioned, communication was a real issue for some people. Only 50% of respondents felt they'd received enough information about their treatment needs or their wait or delay. And we asked what, would make things better for them. And listed on the slide are some of the suggestions. So, top of the list, people wanted improved information about their wait. They wanted reassurance that they were on a waiting list, and they wanted to know how that list was prioritised. They also said they wanted regular updates on their waiting times. As I said, some people said the stress of not knowing was affecting their mental health. Others wanted to know for practical reasons. And then there was an issue around consistency of the information that people were provided with. So for the last of my slides, I just wanted to go through the 4 recommendations that we make in the report. So we've highlighted that there's considerable disparity between the types of support offered to people and the aspects of life affected. We need to think about this as a holistic care and a system-wide response to support people who've been impacted by elective care waits and that continue to be affected beyond the point at which they receive their treatment. Drawing upon and making best use of the services across all of the partners within the ICS. There's clearly better need for better communication and transparency, including regular checks with people on their condition and a reminder of the full extent of support that's available to them. Inequality was evident within some of our data. However, due to some small sample sizes, we weren't able to draw firm conclusions, but we would suggest that there's more work that needs to be done in terms of understanding how impacts are affecting different communities. And finally, our report provides a baseline measure from which the ICS and acute hospitals can check whether their local plans are making a difference for people. So there's a recommendation there that there's a follow-up survey to compare against this baseline and explore any further knowledge gaps. And I'm going to hand over to Angela now.
Thank you.
Thank you, Susan. I just wanted to share with the board some of the work that's already in place, and I think it was a timing issue in terms of when the survey was carried out and some of these items in place. So the Together We Are Better work stream was established in response to the elective recovery aims, and one of the key pieces of work that the TWAB group worked on was the development and the go-live of the Suffolk and North East Essex Wellbeing website. This website contains information and links to mental health support, exercise, housing, financial support, and that's broken down into what's available within each alliance. There was primary care promotion, standard messaging was sent out to practices to promote via the websites, to put on their AM screens, and also to put some information on the bottom of their prescriptions. And a link has also been added to all practice websites. Alongside that, we developed some patient information leaflets which are available in hard copy and electronic format. And we commissioned some easy read leaflets for patients with learning disabilities, and these are distributed by the LD specialist nurses. There was also a public awareness campaign around the website, which was included radio and newspaper adverts, as well as social media adverts on buses, etc. And we also did some targeted promotion for some vulnerable groups. Referral acknowledgement letters are now sent to patients that have been referred to Ipswich Hospital, and included on that letter is a link to that website. And that website contains information regarding expected wait times broken down into specialty. And that's the same across all for Colchester and for West Suffolk. Alongside that, the referral acknowledgement letter was also updated for Colchester to include that information. And North East Essex established a pre-surgery wellbeing pathway where identified patients were referred to social prescribing support. And the West Suffolk Waiting Well pilot as well, which took a similar route. Next slide, please. So after all of that work that's gone on and continues to be in place, the West Suffolk Population Health and Place Development Programme continues, which is being led by Helena Joplin. But also within East Suffolk, we're developing an integrated neighbourhood team patient tracking list. And that's where, once patients have been sent their referral acknowledgement letter, the INT coordinators will proactively contact those patients and offer support, either signposting or direct referrals to a social prescriber. A working group's been established to work through what the processes are so that we can have a consistent approach, and we're hoping to go live with that in the new year. Next slide, please. The TWAB group carried out a tabletop exercise to identify this work that's already been in place and map to the 3 recommendations that came out of the Health Watch report. Next slide. So as you can see, I won't read through them all because I've already just talked about that. But you can see that, you know, for instance, the wellbeing website in terms of supporting people waiting, and the Suffolk Waiting Well, West Suffolk Waiting Well project. Next slide, please. again, just mapped, and I won't repeat that. So if you want to go on to the next slide, and then again, let's go to the last slide. So the Health Watch report highlights the breadth of the impact that waiting for elective care has had on people's lives. And as Andy and Susan mentioned, that a holistic system-wide response is required, which addresses the impact of the delays as well as any long-term consequences. So whilst it's recognised that managing this is not the sole responsibility of the acute hospital, and it's previously been part of the planned care programme of work, we must acknowledge and engage with other partners within the system so that we can address the needs of our patients waiting for treatment or care. So although there are a number of initiatives already in place, and it's a consideration in all the work that we do, there's potentially more that can be done. So it's our recommendation for further work to address the findings and recommendations of the report, that this should take place at a local alliance level and be integral as part of the Live Well domain with the programmes, which is how the ICB is going to be working moving forward. Thank you.
Okay, thanks very much. Thanks, Susan. Angela, just hang on to the microphone, Angela, in case you need it. Frida.
Sorry I was late this morning.
Don't worry.
I couldn't find anywhere to park. In fact, I probably parked badly. Thank you for that report. That's really interesting, and particularly interesting because I'm a GP, and we see the impact of the wait on primary care, essentially, and the fact that you've described so well the impact on patients in their mental health and their family, and even down to not being able to walk on a bunion. It seems trivial to us, but it can be really deeply affecting when a husband and wife want to go for a walk and they can't, and this the weight does affect even small things like that. But the problem is that often the patients then come back to us and they become they enter into a spiral of analgesia, which is not good for their health either, in terms of ever increasing analgesia to help them wait. Also, they ask for several letters to expedite, which takes up our time. And that comes to my question. I didn't quite understand what primary care promotion is. If you could just explain that to me, because I don't understand where the capacity is in general practice any further to help in the system.
Yeah. Yes, it's okay.
Can't hear myself. Yes, so thank you for that question. So the promotion was around the promotion of the website, so that, not necessarily all of the other activities. So it was around the new website, so that patients could have access to it and using it in any of the communication materials that you have, but also so that your staff within all of the practice, not just the GPs, are aware of that resource, which links in everything that's available across the ICB, broken down at alliance level, rather than having to go and look for that information. It's all drawn, so it's not rewritten, it's just links or information where signposting where patients can go.
I just
follow up, quick one, Frida.
So very quickly, just thank you for that, because I didn't understand that, so thank you. That would be really very useful indeed. And also, I have spoken to SNES Medical Director, and we are trying to, I think she is trying to establish a letter that goes sort of midway of the wait, to say you are still on the list, don't worry, to reassure patients. And I think that's a really good idea, to take the pressure off GPs as well.
Yes, exactly, yeah. So we're continuing to work with the access teams at ESNEFT and West Suffolk in terms of how we can better communicate, because it is, as Susan said, it's that not knowing which causes concern and worry.
Okay, thanks. Just recognising, I think the board is recognising how important this agenda is, of course. If in no other way that I've now got 6 people who want to ask questions, bearing in mind time, what I think I'll do is I'll take them in twos, and then Angela will see if you can deal with 2 in 1. We'll give it a go. We'll give it a go. And we'll help, I'm sure. So first of all, I'm going to go to, both Steves actually, Steve Feast and then Steve Curry. So Steve Feast first, please.
It's a question for us as a board, really. Given that 1 in 6 of our citizens are currently waiting on a list. The numbers are huge.
Oh, sorry. Sorry, my fault.
The numbers are huge with 1 in 6 of our citizens on a list. I just wonder whether we should have an active waiting list strategy as an organisation, where we work through the Integrated Care Partnership and wider,
and through quality and safety, because we know that the monies to be saved, the readiness for surgery to be improved, risks such as smoking, alcohol, obesity, etc., can make such a difference to patients' outcomes that this isn't something we should look to Health Watch to solve, but we should actively have a dynamic strategy to solve ourselves as a priority.
Thanks. And that may well be a rhetorical question from the presenter's point of view, but we'd be interested in the feedback. And Steve Clark, I'm so sorry, did I refer to you as Steve Curry earlier? My fault, sorry, Tanya.
Being confused with an Olympic gold medalist?
Well, you know, it's normal, it's normal.
Even though standing up on ice skates is an impossibility for me. No, I just wanted to ask about the consequences of the health inequality stuff you picked up. You talk about colleagues in the elective care sector having updated the impact assessments. Given this is a system-wide thing, is there anything anywhere else that needs to be done? And particularly, we've got some recommendations, many of which have been either acted on or partially acted on, so they're in progress. I didn't see any differentiation in those between groups or whether they be ethnic, majority populations or whatever, or socioeconomic. And your example of the couple, I think it was a couple, but the family, in which one partner got an operation, the other couldn't afford it, I'm sure colleagues who are out in the system will know there are plenty of people where the option of one of the partners getting the operation is an impossibility. So there's a differentiation, differential impact, I am sure, on the basis of money. And have we differentiated any of our responses on the basis of any factor whatsoever? Or are they all broadcast to the nation? Sorry, that's a bit simplistic.
Interesting points. Do you want to comment on either or both of those? So the waiting list strategy and then differentiations.
No, would definitely welcome the Steve Feast's proposal of that action group, whatever you want a task group, you want to call it, as long as there are independent and maybe the voluntary sector involved in that, because of the social prescribing element of everything else. We haven't mentioned it specifically, but it's there to support people whilst they're waiting, based on the findings that we had. Definitely support.
Yes, I would support that as well. And I think because, using smoking and weight management as just one example, there's loads of things that different programs of work, and I think it needs to all be brought together and in terms of supporting our patients. In terms of the inequalities data question, I probably agree, actually. We did an impact assessment on elective care. The trusts have a PTL specific for LD patients, but there's more work that needs to be done in that area, I would admit, yes.
All done? No. Noted. Okay, thank you very much for that. Let me go to Lisa next, and then Nick, I'll come to you. So Lisa.
Thank you. So I was struck by the difference between 80% of people had been offered support, but only 39% of people felt it was the right help and support. And I just wondered, the respondents that you were working with to get the problem kind of clarified, are they working with you to help to make sure we get the right response this time? Is there still that co-production element to the improvements we're making?
Go on.
Sorry, I don't quite follow.
Sorry, let me put it in a different way. So the respondents that told you that they'd only 39% of them had the right information and support, are they still working with you on the improvements?
No, so this was a one-off survey that we've done. So yeah, they just responded to that survey. So there's no ongoing work with them at the moment.
Okay. Is there? I'm just wondering how we make sure we get the right actions. And
But it may be a follow-up that's needed. So about 9,000 SMS text messages were sent by the 3 hospitals together, and that's what brought about the main response. So they were a one-off, but we know that half the people that were offered support felt it was the right support, And I think the rest of the recommendations point out where the gaps are.
Okay, so there may be I think, Lisa, you're flagging for the board's interest that whether there is a resource there in co-production terms. Yeah. But if there is, it needs to be developed, I think, is the answer, isn't it? Let me go to Nick.
Thank you, Chair. I mean, first of all, I'd like to thank Health Watch and indeed the ICB for this piece of work. This might upset my performance director, Ed. I don't really get too upset by numbers, but I get very upset and have an emotional response to stories. And I think the more that we can hear and listen to the impact of long waits, rather than a percentage or an RTT number, will hopefully not only inform us as leaders, but take us to a different approach to how we address some of these real challenges. I also think it's really important that we share these stories amongst our staff. As we alluded to earlier, we're going into some quite tricky waters in terms of industrial actions and everything else, and I am not for 1 minute suggesting that it's not somebody's right to take action if they feel it's what they need to do. But I think that we need to be sharing with ourselves and our systems and listen to ourselves very clearly about the real impact that our current challenges with productivity are causing the people that we serve, and that any further action that we take will have a real direct impact on the lives of the people that we serve. I think also for me there's a question perhaps an answer. There is something about who owns patients on waiting lists. So I think there's absolutely a belief that once they're referred into the acute or the community trusts, or indeed to the mental health trust, that they become that organisation's patient. There is a belief from some in those organisations that they don't become that organisation's patient till they've been seen, and they sit for, frankly, if it's only a few weeks previously, then it may not be an issue, but now that it's months and sadly years, I think it is a much bigger issue. And I think this is absolutely where the Alliance can step in, because the Alliance is there to represent all of the different bits of the system and is there to then provide some solutions. Finally, just around some assurance, we are now training our consultants in MEC, which is Make Every Contact Count. When I first talked to some of our more seasoned orthopaedic surgeons about suggesting that they talk to patients about their mental health or their lifestyle or around their, for example, debt advice, they were understandably quite anxious. But now that we have, for example, the website and everything else, the fact that they are simply there to act as signposting, and we are now working with particularly the third sector around being able to signpost. So moving into that holistic care that you talk about, that it's just not the knee or the hip, it is about the whole person, and recognising that those long waits particularly are causing real harm to not only individuals but to their families, and offering some solution to that through those outpatient attendances. Thank you, Chair.
Thank you, Nick. And a number of nods around the table throughout Nick's comments there. So I'm going to take that as read and agreed, if that's okay. Paul, I'm going to come to you next, and then Richard, I'll come to you, but also you might pick up comments on the actions that going forward in your final comments. So, Paul?
Thank you. I'll try and not to repeat some of the comments, because I jotted a few things as I was listening to the presentation. So, for me, my immediate reaction is you can't communicate enough. That's very clear. I think you can see there's an awful lot of hard work has gone in to try and do that. I think we sort of heard the elements of socio-economics being mentioned. I think that's hugely important. It is everybody's business to make sure that we look after patients well, and I think that's a point's been well made around the Alliance space, and we can work with partners to address some of the concerns and risks that our patients were on our waiting list. The other thing that really struck me were a couple of things. Reflecting, is it any great surprise that there will be some dissatisfaction when actually the solution is having the elective procedure that is required to make the patient's life better. So actually we should accept that actually there will be an element of, whilst we work really hard to try and address the issues, the ultimate goal is to make sure the patient has the right procedure. I think so. Again, we should explore that a bit more in terms of the impact. The other thing which struck me was the willingness to travel is a really, really important point for me, and sort of indicates some of the approach we've had in system around mutual aid, and we've seen an awful lot of mutual aid system with both trusts working incredibly hard to try and make the waiting list equitable across the whole system. So again, that's a really, really important point I think that comes out of this presentation. And then on a bit on health inequalities, clearly we now monitor health inequality as part of our data, but clearly we need to do more work. And again, from a Health Watch perspective, I wonder whether we could actually join forces a little bit to look at the work we've actually been doing to see how that marries up with what you've been doing, see whether there are any gaps in what we're doing. And the final point around the strategy, I think we probably have the makings of a strategy, we just haven't joined all the dots up together yet. So I think to have it in one place to identify the gaps would be really, really helpful. Thank you.
Okay, thank you, Paul. And again, I'll take that as, I saw you nodding, I'll take that as noted and agreed. Richard.
Thank you, Chair. I think Nick put it eloquently, some of the things I was going to say around that the impact of reading that report. It's shocking and upsetting, some of the comments that were made, and I agree with Nick that we absolutely need to put those to the fore in terms of our work about the impact that it's having on residents across our local geography. And I'm really pleased we committed to this piece of work, and I think we should recommit as a board to running this survey again in a year's time and hold ourselves to commitments that we need to make to ensure that we get it's improved from what we've seen now. I think as Steve Clark said, because I'm covering both Steve, so Steve Clark, really keen to understand the inequalities lens on this as well, and got a little bit of that through the report, but I think that's something we need to do some more work on to see how it's differentially impacting on our local communities. I think there's an opportunity with the joint forward plan that the ICB needs to produce by March to make some bold commitments as a board to how we not only support those who are waiting, so the immediate need, but as Steve Fee said, some of the things that we need to commit to and should be committing to on that primary and secondary prevention, because this is only going to get worse over the next few years given the sheer size and scale of what we're trying to deal with across our local patch. In terms, just to take your point, Chair, on how we take it forward, obviously Paul's taking a lead role on elective, but we do have the elective care committee as a board, and I would suggest that's the place where we should be anchoring our joint response around this. And also, I think we should make, in my view, a commitment to running the survey again, and also looking at how we can build on that, perhaps with some people who may be willing to work with us on this, so in that co-production fashion, on designing some of the solutions at Alliance and at ICB level, because I think some of these solutions actually could be done once across, as well as working in each of the local patches.
Richard, thank you very much. And so, colleagues, I think we are very grateful to our Health Watch colleagues for all the work that's been done on this. So thank you to teams, individuals, and I'm sure that there'll be a lot of people involved as well who perhaps aren't here today. So thank you very much for that. The board really appreciates the work that's been done, is very supportive of taking that forward, specifically, as Richard has mentioned, but also support for that work with alliances and repeating the, shall we say, or further developing the future work and future surveys in the way that colleagues have described, so that we actually get to a better outcome for the people who we serve. So thank you very, very much. Everybody content? Thanks very much. Now, okay, so we're already 20 minutes behind and we're only 50 minutes in, and we were supposed to be doing this really sharp, so we'll have to accelerate, otherwise there will be no coffee. So, the Suffolk and North East Essex Training Hub, item 8. Amanda, over to you and to introduce our colleagues.
Thank you very much, Chair. So I feel incredibly lucky to work with 3 talented individuals who are here today, Dr. David Cargill, Julie White and Lisa Booth. And they, with their team, have done some truly amazing work to support our primary care workforce over many years, actually. And they're doing such a magnificent job. I felt it was important that they came along today to really showcase their great work across SNE to us as a board. So without further ado, I think, Julie, you might be kicking us off. Thank you.
Thank you, Julie, and welcome to Julie, David and Lisa. So all yours.
Thank you. I thought we'd stand up and just move around a little bit. Good morning, everyone. Thank you for inviting us to this morning's meeting. I'm just going to say, I'm Julie White. I'm the Training Hub lead. I have with me Dr. David Cargill, who is our GP and Physicians Associate lead, and Lisa Booth, who is our Nursing and Allied Health Professional lead. I hope by now that you all are becoming much more aware of the work of the Training Hub. The Training Hub exists. We're funded by Health Education England and NHS England, and the aim is to drive all of that money into our system to focus on developing primary care, and at the moment our core function is general practice. You can see from that slide that we cover an awful lot of different elements, but there's only 2 elements from there that we want to focus on today. We want to talk about workforce planning and recruitment and retention. Workforce planning is absolutely key to everything that we do. We need to understand what the patient need is. As the previous presenters talked about, it's really important that we understand individually within organisations and also as a system, what is our patient need, identify where the gaps are, and then we can plan the workforce to make sure that we've got the right skilled workforce in the right place to deliver high quality patient care. We've been incredibly lucky as Three in the fact that we've secured a place with Health Education East of England on their Workforce Masterclass programme. This is enabling us to build on the learning that's come nationally and regionally on how to develop a workforce planning model. Our aim is to actually, for us to complete this training and then roll that out across our teams, and more importantly then across the PCNs and the practices. A key part of our workforce is our non-clinical staff. In general practice, they make up just over 50% of the workforce, and they are absolutely crucial in delivering patient care. I'm really pleased to be able to share with you that one of the few training hubs that have actually appointed a dedicated non-clinical lead. If you think about it, that group of staff not only are the receptionists, but they're the practice managers. Increasingly, there's all the new roles around. We've just mentioned earlier today the importance of social prescribing. So we really are here to try and develop the existing non-clinical staff, but also to look at how do we recruit them. I'm now going to pass over to Lisa.
Try and multitask and hold all these things at the same time. Hi, everybody. So I'm here really just to talk about the Training Hub's role in supporting our multi-professional team before I hand over to Dave to talk about the GP. So our role really is to support all the other multi-professionals that make up primary care, including all our nurses and allied health professionals. So some of the things that we focus on is working to support student placement expansion. You know, that's really key. If we're looking at workforce development, we need to expose our students to primary care and get them to choose it as a first destination career. That's really, really something that we're very passionate about. We also support newly appointed and new to practice practitioners that are coming in through induction, preceptorship and fellowship programs. So really help to develop that staff as they move through their career in primary care. And also we look at retention, so you know, supporting those that have been within primary care and supporting through CPD, career development, peer support, professional development, health and wellbeing, and career conversations. So all of those things, we have a very good team in the Training Hub that's made up of GP nurses, allied health professionals, ambassadors, from paramedics to physios to pharmacists that are still working in the system and know the system, so can you know, understand some of the complexities that are happening in primary care. So that's really important. So just some of the things that we've managed to achieve through the development of our programs. So we have a rolling program for all clinical staff, and we've had over 2,000 bookings on that. We've commissioned many programs for our allied health professionals and nurses to access, and we have great
access to those, as in the practices are accessing more programs to help support them. We've got student placements, we've got summer school opportunities for pharmacists that we introduced over the summer, which was great. We have our legacy nurse role, so capturing those nurses that are thinking of leaving, but actually have got so much skill that they want to pass on their knowledge, and we're capturing those as part of a bank contract that we have, which is great. And just to mention the forward-thinking, the upskilling and the apprenticeships, which I'm really passionate about. And just to give you a very brief story, one of our GPN nurses, newly qualified, just 2 years, started in her practice as a receptionist, worked her way up as assistant practitioner, wanted to be a nurse, but didn't want to do the traditional route, wanted to stay in her practice, wanted to develop, and chose to do a nursing apprenticeship. And now she's qualified, working back in that practice where she started as a receptionist all that time ago. So it's really, really fantastic that people are choosing to do that. So our current focus really is increasing those student placements. We want people to come in. We need to grow the workforce. It's a priority. So we have GP trainees that need places as well. So we're looking at, increasing the amount of learning organisations that we have across the region, as well as working with the local HEIs to increase those nursing and AHP student placements. So it's really exciting. And just to mention that we hope to roll out our PCN Educator project across the region as well, which will help further develop all those training practices and workforce development and training for all of our fantastic staff across primary care. So thank you. And I'm really excited to be part of this journey with the Training Hub. So I'm going to pass over to Dave.
Thank you.
Thank you, Lisa. Thank you very much, everybody, for the opportunity to come and present to you some of the good work that we're doing. Oh, don't give me that as well. To support GPs across our system. So you all know, nationally and locally, we have a shortage of GPs. To attract trainee GPs into the profession and retain those already in it, we must support GPs throughout their career, whether that's when they first start, right the way through to retirement. The Training Hub has implemented a vast array of initiatives to support this. These support from fellowships to attract GPs into posts, coaching support, development of peer networks, education, and of course the development of specialist interests. Would you move the slide forward for me, Julie? So this slide just represents a small snapshot of some of the work that we're doing to support GPs and some of our unique initiatives that we have. So the first is the GP Support Hub, which is an advice and guidance service for GPs, essentially a citizens' advice bureau for GPs, if you'd like. We've got Welcome Back to Work, that provide a bespoke and individualised support package for GPs not currently in work. They provide specialist vocational rehabilitation, bespoke re-enablement and career support to individual GPs seeking to resume work. Many GPs have been introduced to the workforce in our system because of this specialist support that would otherwise have been lost to the system. And finally, coaching. We're all aware of the benefits of coaching, so we, as a training hub, have commissioned two providers. The first is Akiza, a well-known, recognised local provider of coaching and mentoring, and that's available to all primary care staff. This isn't exclusive to GPs, it's to the whole workforce. And secondly, we're working alongside GPS, a company to actually train up local mentors in our system so that they can move forward and support their staff moving forward locally. Next slide, please. So it's very easy for me to stand here and wax lyrical about all the services that we're doing in the training hub to support the primary care workforce team. I think Nick mentioned it earlier. Stories are a lot more powerful, and I think they're better at spreading the word and often are more helpful at telling us how good the services are. So next is an audio file. I'm on the clicker.
I was the senior partner of a thriving NHS general practice when burnout knocked me right off my feet. It was brutal. It took a good long while to recover, and I came to the conclusion that NHS GP life and I were just not compatible going forwards. That it was time to draw a close to that career and to look for some other way to service my mortgage and support my family. As someone still in my 40s, it was a really tough decision to take. Around that time, I was introduced to two extraordinary women, Lucy Henshaw and Penny Flack of Welcome Back to Work. And it was through their incredibly compassionate, intuitive and gentle support that we explored together the options available to me. They helped me construct a way to test the water. I really wanted to prove to myself that I didn't like the job anymore. I wanted to spend some time in general practice to confirm that my decision was correct, that I was going to leave for good. And yet, the outcome of that supported journey and the transitional phase they created and travelled alongside me is that I returned to NHS general practice willingly and enthusiastically, taking on a salaried GP post a couple of years ago that is ongoing. Moreover, since then, I have taken on additional roles in the wider primary care environment, and I am now working full-time doing a job that I thought I would never do again. I know, with all my heart, that had I not been introduced to Welcome Back to Work and had access to their bespoke and personally tailored support, that I would have left the landscape a long time ago. And I would not now be a Suffolk GP working right at the heart of things as I am now. It isn't easy to explain the depth and breadth of support I received, including reconnecting with other GPs, people just like me, facing return to work challenges just like mine. When I was so isolated, lost and feeling as if I was the only GP in my position. I was really listened to and understood. I was met with kindness and curiosity always, and not expected to match any artificial criteria or follow any set script. Support, advice on professional challenges, and practical assistance resuming work all evolved seamlessly over time. All of it at a pace and in a direction of my own choosing to maximise the chance of me thriving in work. Welcome Back to Work is just so kind and enabling. We are lucky to have this support available locally since 2018, and I hope it will be secured moving forwards for the sake of others like me.
Thank you everybody for listening to that. On a personal note, this may or may not surprise you, but that is actually my story. I am now back working full-time as, two roles as a GP and obviously leading the training curve with all the vital work we're doing for primary care. Next slide, please, Julie. So I'd just like to leave the presentation on really two key messages. So the first one is a system-wide recruitment campaign for general practice that we're just about to embark on as a system, and you will all hear lots more about that over the next few weeks. And secondly, as Andrew alluded to earlier before, that the BMA have published safe working levels for primary care. I wonder whether as a system we can actually seize this as an opportunity and work collaboratively together as a system to support primary care to work to the safe BMA working levels, but at the same time getting them to adjust their model of care to make sure that they're seeing the right patient, the right skill set. I think as a system it's a huge opportunity, and if we are one of the first systems that can go out and promote this, this will be a huge recruitment campaign for GPs. SNE would be the place to work as a GP, and we would really attract people into the area. Thank you.
Wonderful. Thank you very much, and thank you for that personal experience as well. So really hard-hitting and well received, and a commonality of theme as well with our previous item around collaboration as a system. So not only from a patient focus and a patient experience, but also from a workforce focus. So thank you very much for that. I'm going to go to Ed first, and then Nick, and then Richard. So Ed.
Thanks, guys. Excellent presentation. My question was around how we develop strong teams, because often we talk about developing GPs or nurses or AHPs, but when I visit practices, what's very obvious to me is that the practices that are really thriving are the ones where they have a really united team across all of the different professionals and individuals. And without wishing to embarrass Frida, Great Bentley is the perfect example of a practice working as a team. When you visit other practices, you hear different messages, and it's obvious that you're not united, and therefore they're finding it more difficult. So it's just with the training curve approach, what are we doing, or what might we do to develop that team culture in our surgeries?
If I could answer that. If I could answer that, please. I think a lot of the people in the room know that my background is management. I've been well supported by the NHS and people in this room to actually develop my management skills and training, and actually to take both local and national accredited training schemes. And I think it's the one thing that really resonates with me is the fact that there's been a lot of work, there's a lot of initiatives, but there isn't often an opportunity for the PCNs and the practice teams to actually step outside and use what we would all use if we were changing things, you know, a change management model, to spend some time actually just understanding what the issues are. Quite often the practices actually have the solutions, they just don't have the headspace to be able to do it. We're wanting to try and roll out that support under the guise of workforce planning, but I think also talking to the 3 alliance leads, we've recognised the fact that we could do more with the current shutdown and training and education and development structure that's in place, both at alliance level and also at local level, because West Suffolk and North East Essex actually allow the practices to have some space to actually do you know, team building. But I think what they've perhaps not had the opportunity to do is to be able to access some facilitators or some training to be able to enrich that. If you're really busy and then someone says, oh, by the way, you can have next Wednesday afternoon to do some training, somebody's got to work out what that training programme is going to be. So we hope that what we might be able to do is to do some of that back office work for them so they can benefit from that training without having to have that headspace of where do I find a facilitator and how do I put it on. So that, at the moment, are our initial thoughts. We're very happy to continue those conversations.
Okay, and it's going to be a long dialogue, isn't it? So, okay, Nick.
Firstly, thank you very much for highlighting the issues which I'm obviously well aware of, and for all the support you've done. I've been involved in various of these projects, and in fact I've got some follow-up meetings with David this week and next, along with Frida, about various initiatives that we're looking at. I just wanted to sort of say to the board, really, we can't overstate how busy general practice feels at the moment, whatever the data suggests, and I think the issue is, in general practice at the moment, we need help to help ourselves, because I think quite often as small practices, once you are really busy, what you do is you start looking in, you work harder, and you stop looking at the wider support, training, things that actually we need. So in terms of anything we can do to improve retention first, and getting the time to train and then the space to train, and that was the other thing that I know is not in the gift of the training hub, but the estates issue of, I would love to train more people. I'm in a new purpose-built building as a small practice, which apparently has capacity for 12,500 patients, and we have 7,500. I've already now got several days a week with not a single room spare, despite the fact we've only got 2/3 of that capacity. So, and also the other element is, while ARS through PCNs, this wider pool of people we can employ is brilliant, they all need slightly different support and slightly different training, each of these skill mix colleagues, and it's not something general practice has done before, and we don't have the advantage of a big workforce support and training sort of hub in individual practices. So it's just, there is more and more work that you guys can do, and I'm very grateful that you've started it and are building it.
So just let me, I'm going to bring in Frida before Richard, if that's all right. But David, I saw your hand raised there. Have you got the microphone? Yeah, you have, yeah.
I think really vital point, and I think as a training hub we are passionate about helping primary care change the model that they provide, and by that I mean that we need to adapt to the multidisciplinary team. GPs are there now. We've got so many different members within our team. No longer do we sit in our rooms and see our 40 patients a day. We're actually sitting in our rooms, seeing our 40 patients a day, and supervising and debriefing our AMPs, our paramedics, our physician associates. And it needs to be built into the model of care that we provide ongoing from now on.
Okay, thank you very much. And I think as well, I saw a number of people nodding when, Nick, you made the point about we need help to help ourselves. There's a very emotional intelligence point there, I think, if I may say. Frida, and then Richard, and then we'll wrap.
Yeah, just point to David, I still sit in my room 12 hours a day, 40 patients as well. So like, we are still doing that. I'm glad you make that point. My issue is over the BMA safer working practice, and I'm really glad that you brought that up, because it is a really vital document for all GPs to read, and I've really pushed for my partners and friends to read this document. The only problem is we had a discussion in our partnership about it, and we can't do it alone. I think any practice that goes out alone, and I know of one practice that is contemplating doing it alone, I would guide them not to do it alone, because I think it will bring about quite a lot of pushback from the local population of patients, and it's incredibly difficult to work, not to rule, I have to say, but to work to contract without the support of the system. And I think we definitely need that. And I think if we could focus perhaps on the chat with Nick and yourself and myself about how we approach the BMA guidance, which I do support, but I think it needs to be done across the system to make it successful.
Okay, thanks, Frida. Richard.
Thank you, Chair. Firstly, really love the example of the receptionist to nurse. It's clear we need to do loads more on that. I've got an offer, really, and you might already be doing it, but we're fortunate on the mental health front to have a significant amount of ring-fence funding comes in. It links to Nick's point around the fact that we're growing roles that aren't necessarily traditionally in primary care, such as the mental health practitioner workforce, where we know we've got cultural and other challenges around actually rolling that forward. I think part of that is going to be a training need for those, and also links to Ed's point about how you then knit them into a wider practice community. So really interested in talking maybe offline around, is there any more we could do, actually particularly with that cohort, because I think there's potentially brilliant opportunities through the training hub for them as well.
Okay, thanks, Richard. And Peter assures me that this is a very quick point.
Just one more thing I wanted to do that hasn't been said so far. I think the connections with the hospital clinical workforce is really important, and we started talking about a perfect week with general practice, and then we said, well, we need to speak to the hospital about it, and that's generated a lot of really interesting conversations, because a lot of work that is generated for each other across that primary and secondary care boundaries. I think how we bring that in, and the fellowships model that you described is critical to our strategy as well.
Thank you, Peter. So, colleagues, I think we are we not, recognising that our biggest asset is our workforce, and in this case we're focused in the way the paper describes around the primary care training hub, but that actually we are nothing without our workforce, and unless we get that right and continue to improve, then we won't provide the service that our patient requires. So we're determined to make progress in this space, and we're very supportive. Thank you, colleagues, for the paper, and Amanda for bringing it, very supportive of this process, and look forward to further developments as described. Everybody content? Great. Now, help me here. Items 9 and 10, the ICP update, and then the alliances updates. So Susanna, Maddie, Laura and Peter, could I ask you to give, when I come to you, one highlight, if you would, and then perhaps there may be an offer for offline engagement if there are further questions from colleagues, if that's acceptable. So Susanna, over to you first.
Okay, so I've been given the challenge. So my highlights would be just to encourage board members to use the opportunity of the engagement period that we're in at the moment around our strategy. So go to our website. There's a lot going on at the moment with different conversations. The biggest thing that's coming through is that what matters to people, what people are saying in every corner around our engagement is, it's not always things that are going to cost us money. Some of those things are about just the quality of relationship that we have with people as a health and care system. That's coming through very, very strongly.
Lovely. Thank you. Any specific questions for Susanna? Otherwise, the offer for offline engagement is there. Received and noted. Maddie, over to you for item 10, the first highlight, please.
Thank you. So I suppose the most specific item that I would like to highlight is the current progress of our integrated neighbourhood teams. So I'm really pleased that all integrated neighbourhood teams now have a single leader across the social care and community sectors. All integrated neighbourhood teams now have a sponsor, and we're really pleased that Mark Pattinson from NSFT is now sponsoring the Felixstowe INT. So that's a direct connection between our teams on the ground, our Alliance Executive Delivery Group and the committee. And that co-location, there is a plan for co-location for every integrated neighbourhood team now. And I think everyone will have been very pleased to see at lunchtime our nursing colleagues and our therapist colleagues dashing over from Constantine House to Endeavour House. And that's such an important development. And last but not least, on the 13th of December, we will be making our forward plan for our integrated neighbourhood teams based for the first time on real population health management data and supported by the skills and experience that people have been gaining through the One Team programme, to the point about team. So I hope that was quick enough.
Thank you, Maddie. Any questions for Maddie? If not, again, offline, you're very happy to receive any questions. Laura?
Thank you. I'd just like to really highlight the work that's been happening within our Dywell domain. So this was reported at both our October meeting and our November meeting. We had the domain spotlight report that highlighted the progress that's been made around supporting people within being able to die in their preferred place of care. And then in our November meeting, we had the report around assets to support with a number of key recommendations being made, and we're very eager to take the learning from this domain across to our other domains as well. So they're my highlight. Thank you.
Lovely, thank you. Any questions for Laura? Otherwise received and noted, and again offline if need be, direct. Peter?
Thanks. We've been doing lots of work to adopt the Live Well domains in the way that we're operating, and that includes a lead from around the Alliance Committee table to sponsor each of those domains and our 3 enabler domains. And I think that's proving really helpful as an organising force. The other thing that's really dominant for us at the moment is primary care premises, and every meeting has some kind of primary care premises conversation or plan coming forward, because we're playing catch up in terms of our capacity, and that's a key planning issue for us for next year when we get there.
Lovely. Thank you, Peter. Questions for Peter? None. Otherwise received and noted, and again offline direct if need be. Thank you very much. Now, what I suggest we do, the next paper is Digital Care Technologies, Sue and Patrick. If we deal with this promptly, should we have a coffee break? And therefore the pressure is on you both. That's the offer, if we can deal with this promptly. So, Sue, over to you.
Just, we do have a slide set.
You do, I know.
Sam is here to present that. Okay, yeah. So, Patrick, I don't know what you want to share, but we're really pleased in Suffolk to be able to share with both the provision and the development of digital care solutions for people so that they can live as independently as possible. We're keen to be able to share the impact so far, as well as provide the opportunity for the board to consider the potential for the future of digital care across the system.
Just to add, we feel the same in Essex. I think we're only scratching the surface at the potential of care technology. We've had some really successful outcomes from the work that we've done with Millbrook, where our preferred provider, but I think the opportunities to really develop it further in all of the alliances across both SNE footprint but also across the Essex footprint, I think that's where we need to explore. I think the slides are self-explanatory, but happy to take any questions.
You're both happy to go straight for questions? Or... Oh yeah, go for it, go for it. There is a microphone on its way to you. Here it comes. Okay, all yours.
I'm the Digital Care Innovation Lead for Suffolk County Council. I know some of you, not all of you. So yeah, you've all got the slides, they're quite self-explanatory. There's a really good business case for care technology, and increasingly you're seeing care technology and health technologies being mandated centrally, stuff like virtual ward, for example. So the more efficiencies that we can get in terms of integrating our approach, the better it will be for the people living in Suffolk and in North East Essex. So in the slides there's a few specific examples where we're doing some integrated work already. So in West Alliance we've got a really good demonstrator called Cassius Plus, where we're specifically looking at joining up care and health technologies to support community teams through integrated neighbourhood team function. And there's also some opportunities we've put into the hospital discharge pathway in West Suffolk Hospital, which we're already looking to replicate. The business case is fairly strong. What we do need is to think about how we plan this in terms of kind of funding and development and structure into the longer term. It's not just about the technology and the data, which are really important, but fairly easy to do if you get the right providers. It's about your kind of culture, your transformation assets, how you think digitally minded in terms of your whole system capacity, and there's lots and lots of opportunities. So I'm to any questions you might have around that. And I did put some stuff at the end around things to think about, but it's an evolving piece. So.
Okay, that was lovely and brief. Thank you very much. And the point you made, I think, about culture is really important. We've got to shape ourselves to adopt and improve all the time, haven't we, in this respect? So, Ed, over to you.
Thank you. It's obviously been quite a brief presentation, but this is nationally leading work, so I could just be really clear on that. It's a huge asset, and given all the challenges we've got, we need to think about how we can accelerate it further, in my view. So really great to see the work in West Suffolk, where I think we're starting to integrate with the health approach, but kind of the question is, could we look at that across, in North East Essex with Patrick, colleagues, and yourself in Ipswich and East, and Waveney too, of course. So it's just your sense on the doability of accelerating this work is kind of my question.
So we've got the right framework to be able to do that. I think from a Suffolk perspective at least, Patrick, from Millbrook, I'm sure it's the same, but we set up the service so that it could be as flexible as possible, so we could integrate different devices, so we can line up into different platforms. So it's really agile, and we've proved that already in West Alliance in the work that we're doing around Cassius Plus. It's taken us quite a long time to get the governance stood up around it, as you might expect, particularly around things like clinical safety and sign-off. But now we could easily replicate that, in my view, across other parts of the system and across Suffolk and North East Essex. So we put the hard work in the legwork. The service itself is flexible enough to integrate whatever we might want. We've got all the right kind of compliances and governance. So yeah, scalability is absolutely achievable.
Okay, thank you very much. Andrew?
Thank you. Similarly, really impressed with this work, and particularly with this paper, and it's lots of other papers today with the use of patient stories to describe the outcomes. It's really, really attention-grabbing. Are there opportunities to take this work into the elective care waiting space that Healthwatch described and to improve some of those experiences?
Yes, I think we would be able to do that. We've been working on some of the non-elective pathways, as you might expect through hospital, but I think through elective pathways, absolutely. It's just about finding the right technologies, the right fit, and providing the right support around it for the right teams and structures. But absolutely, I think the more stuff that we test and learn, the more pathways that we explore, the more we understand the kind of achievability at scale.
Let me bring in Patrick at that point. Patrick?
Yeah, thank you. Just reflecting on some earlier conversations, one around the announcement of the funding, and whilst we're still waiting to see the detail of the amounts of money that have been nominated, we'd like to see much more of that going into the care market, so strengthening the care market and keeping people out of hospital. And then thinking of the earlier presentation from Healthwatch Suffolk about the elective, you need to think about how you use care technology, not just to support somebody out of hospital, but how they maintain a strong independence in the community. So again, we're thinking around falls technology and new technology and aligning it. We're just about tendering for a community equipment service, so actually how does care tech community equipment fit together, and thinking around virtual wards. The flexibility of the contract with Millbrook allows us to do that, but we're not vetted by that one contract. If we need to expand it with others, then we will do.
That's a great segue as well. Yes, lots of agreement to that, but that's a great segue for Howard. So over to you, Howard.
Yeah, thank you. Likewise, I think this is really impressive, actually, and I'm a massive fan of the sort of shift that we need to make into a more proactive system. And equally, looking at the numbers in terms of cost avoidance savings and improvements in productivity, it all looks really impressive. I'm just wondering if we've done any work. I'm assuming those 6.8 million in cost avoidance is mainly around saved care packages, I suppose. But have we done any work in linking into what the impact has been on the wider system? So, for example, in terms of admission avoidance, that sort of thing, because I think if we can build the evidence case around that, the previous comment around how we sort of invest and scale up, there's a really strong case, I think, to be made into how we improve what we're doing here.
Yeah, do you want to comment on that, Patrick?
Yeah. No, I don't think we have. I don't think we've done enough around admission avoidance and what we could do more. We do a lot of work supporting around the urgent care referral team, so we do in the response team. So we're supporting through that mechanism, putting in care tech, but actually the financial cost of admission avoidance, we're not seeing those in terms of any benefits that we're realising. We've not done that piece of work. It would be a good piece of work to do.
Yeah. Can I just come in on that, Howard? So we are doing that bit of work because we've got a dedicated post in West Suffolk Hospital who's a conduit, a care technology kind of discharge coordinator. which we put aligned with discharge teams, although it was with the intention to support quicker and safer discharge, and it's absolutely evidencing that. It's also avoiding people coming in. They're working with community hospitals, with community teams, with the EIT, with A&E to stop people being admitted in the first place. The greater reach that we get out into community functions, then the more opportunity we'll have to try and scale up that prevention piece. And ultimately, the benefit of care and health technologies and being data-led is if you understand when people are declining or might be leading into acute episode of crisis, and you can put in the right level of preventative support to stop them going into those pathways in the first place. So yeah, so we'll have something on that shortly, and that's one of the outputs of that slide pack. We'll share that because there's certainly a business case there.
Go on, Howard, because I think that's what you wanted to hear, wasn't it?
Right,
yeah, you're happy with that. Good, so work to come. Maddie?
Thank you. Just to offer any support from a kind of Ipswich and East perspective on being able to drive this forward in Ipswich and East Suffolk as well, because there can be few services that we see that have got such savings, but also a 97% happiness rating. That is really striking, as well as a case study. So anything we can do to help.
Thanks, Paddy. I know Paul's really keen to look to do something around that, and I have built in some hospital posts into my budget build for next year, Sue. So hopefully we can replicate what we're doing in West Suffolk across the other acutes.
Thank you very much.
Wonderful, thank you. Nick Hume and then Nick Rayner.
Thanks. Great piece of work. I think across both counties, really encouraged by it. I suppose my one question would be around the equality impact assessment, because we do know that not everybody benefits from the use of technology, and often are most vulnerable, are least likely to benefit from it. So I just wonder whether or not that impact assessment has been done and what it showed.
Yeah, so we did do that as part of the service launch, and I think what we found is that actually we're kind of growing a level of digital skill and maturity with a lot of people who would not normally have access. We're building resilient kind of natural networks by giving people connectivity. It's worth noting that we give people devices and connectivity and the training and skills of how to use them, and because they're digital, and because we could be led by the data, we can understand if people are actually using those devices, if they're giving the right outcome. So it's not that we're just giving somebody something, saying see you later in a year's time, finding out it's not working. We can be really proactive and provide additional support and guidance. And we provide lots of different devices as well, so you can kind of bespokely approach depending on the person's needs.
Great, thank you very much. I'm going to go to Nick and then Ed for next steps. So, Nick.
Thank you. Just to echo everybody else, I think it sounds like a great project. I've been talking to your West Suffolk clinical colleague about it in slightly more detail. I've got some operational questions which are not for here. Really, I just wanted two things which there may not be an answer to. One is about clinical governance, a bit like the same as we're doing with population health management. I just wanted some assurance that when this data is collected, who owns the data from a clinical governance point of view to make sure that it's actually actioned. And secondly, going back to Nick's earlier comment about making every contact count, if we're collecting data, can we just make sure that in this project that is shared across the system partners? So if you've recorded a blood pressure, I'm not then dragging that same person down to general practice to do the same when it's already been done.
Yes, so on the latter point, that's a really good point. This is a demonstration in West Alliance, but absolutely what we want to do is kind of prove the concepts and then look to integrate into other platforms, EPRs, whatever it might be. So ultimately, from a clinician perspective, you don't want to be accessing a different system and looking somewhere else for data. You want it shared across, and that's part of the recommendation as well around that kind of data strategy piece. That just, I guess, the insight, we've got all of this really useful contextual information about people that we could share if we've got the right inputs. In terms of the kind of clinical ownership, that will sit in the demonstrator with the integrated enabler teams, with the coordinators and the community staff there. So they'll have access to that data, they'll be able to make a recommendation on that. So the clinical ownership is kept in that team, that function. The clinical safety and ownership is a big part of the challenge around the governance that we've been struggling with, and it's really important that it needs to have that kind of validation and that safety around it.
Okay, thank you. And, oh, sorry, a very quick one, Frida.
Quick one. I just want to know, when you're coming to North East Essex, what's the plan for across the system?
Patrick wants to come in.
Sorry.
Natasha's joined us, so we can pick up outside.
Oh, okay.
Brilliant. Thanks, Patrick. Great. Ed.
So, I mean, just brilliant presentation. The key thing is we do something more with it. So, Andrew's going to take a lead, maybe working with Sue and Patrick in the first instance to think about how we scale this up and thinking about the business case for for doing so. We've got a head start, haven't we, with West Suffolk, so it's possible, but I'm really keen that we bring this back to the next board with a plan of how we're going to move it forward.
Okay, so plan to the next board. So, colleagues, I think in summary, Sue, Patrick, and thank you, team in the audience as well, that the board is really impressed with this work, and actually it says a big thank you to all for the work done so far, but actually, even more importantly, looks forward to the future development and scale up. And actually, the emphasis that you made as well around system working, again, the same comment. It's a whole system advantage if we get this right, and better productivity, better value for money, more healthy system working, but actually, if we get it right, better outcomes for the patients and the public that we serve. So thank you very, very much for that. Wholly supportive from a board perspective, I think. So, despite the fact, colleagues, that we're 30 minutes behind, I think we ought to take a breath and have a 10-minute break, and then we're going to have to figure out how we're going to still finish at 12 o'clock. So, short break, and see you back sharp in 10 minutes, please. Thank you very much. Okay, everybody, are we ready to go? Thank you, Amanda. Thank you very much. Thanks, everybody, for being prompt. So, item 12, Learning Disabilities Mortality Review. Lisa, over to you.
Thank you, thank you. So, you have both annual reports. You have the Suffolk Leader annual report and you have the Southend, Essex and Thurrock Leader annual report. The way that Leader is managed nationally is in that geographical distinction. So I can't present an ICB annual report, unfortunately, because it's so important that the work is done with our local authority colleagues, that it's done on a council footprint rather than on ICB footprint, and so it should be, to be honest with you. So the LEADER programme seeks to understand why people with learning disabilities and now people with autism die early. It seeks to understand the themes from why people die, and it sets actions. And you'll see that there's some great improvements in both papers. The age at which people die has improved with the learning disability. It's moved in Suffolk from about, I think it's 58 years to 65, which is extraordinary, but it's still way off what we should be expecting for our population with a learning disability. It's kind of pitted against a median if you don't have a learning disability of 85. So people with a learning disability are still dying on average 20 years before people without a learning disability. So it's great that we can congratulate ourselves that more people with learning disabilities are dying in their preferred place of care, that we have made some impact on the age of death, but there's still a long way to go. The Learning Disability Programme covers every single service, every single provider, and primary care, secondary care, mental health. So it's a really complex programme. We know the two things that make the biggest difference to people with learning disabilities is having a really good health check and health action plan from primary care, and we know that empowering people with learning disabilities to understand that, to know what their rights are around a good health action plan, and for them to be in control with their GPs around that health action plan is really great. We've been working in Suffolk with Ace Anglia, who have a peer educator network that support and empower people with learning disabilities to understand their rights and what they should be getting from their health check. And we're extending that work into North East Essex as well. The second thing that we know makes the biggest difference is reasonable adjustments. So it is a legal requirement for somebody with a learning disability to have a reasonable adjustment made in their access and their treatment. And there's some great, amazing work happening. We've got health facilitators working with NSFT. We've got some great work happening in North East Essex, but we still need a commitment from the leaders of our providers and our programmes to understand how people with learning disabilities are experiencing care in your service and in your programme. So are they getting equitable access? Are they getting equity in screening programmes? Are the letters that you write accessible? There's so much to do. So I won't go through the reports, but I would just urge everybody to make sure that everything they do is reducing the variation in death for people with learning disabilities. Thank you.
Thank you, Lisa. Good points, well made. Steve Feast?
Yeah, Lisa, just looking, very good reports, thank you. And just looking through, I just wonder if there's something around swallowing and airway protection that comes up as a recurrent theme. Are we working with our speech language dietetic services to improve awareness?
Yes, thank you. That's a really specific theme that we are definitely working with colleagues to improve. Thank you, Steve.
Thank you, Steve. Andrew?
There was just an item of data that jumped out at me, and I think it's got wider relevance for managing health inequalities. So it was on page 7 of the Suffolk report, where the Institute of Public Care estimates there's 14,000 people with learning disability in Suffolk, but only 3,345 of them are registered. So there's a massive mismatch between what we know and what we don't know. That is the same for many other protected characteristics, and as we strive to tackle health inequalities, I think one of our first tasks has to be to ensure we have good data quality, or as good as we can get it.
Okay, thank you. Any further questions or points? Or are the board is asked to receive a note and support the recommendations which are in the paper? I won't read them out. Patrick?
Just on the annual health checks, I'm just wondering what the actions are from there. I can see that there's in the paper there's the lead of plan on a page. I'm just wondering what the actions are as a result of that to increase that from kind of 66% that was currently there.
Yeah, sure. So the actions, there's many actions, but just to kind of summarise them, is about, as Andrew said, making sure that we have everybody on the register. First of all, that's a really important action. The obviously supporting primary care to deliver health checks and to understand the importance of them. We have a performance pack that we know the surgeries that are doing amazingly well and the surgeries that need more support, and we've invested in health facilitators, LD nurses to support primary care. But the next biggest thing is around making sure that people with a learning disability themselves know that they can have a health check. The action plan is the most important bit, though, Patrick. It's not what happens in that check, really. It's the action plan.
I was just going to say, I wonder what more we could do as a local authority, both from a schools, children and family services and education, but also into adulthood where we're supporting people and how we can become advocates and support people to have a voice. And ask for a health check.
Let me take that away, but certainly Essex County Council are key partners on the LEADER programme. Thank you.
Good point, well made. Lots of nods around the table to that, Patrick. Thank you for that. More great system working. So, received, noted and recommendations and the further work indicated supported. Everybody content? Lovely. Thank you very much, everybody. Item 13, dentistry briefing. Just before I come to Richard, Steve, I think you're going to declare an interest.
Yes, sorry, Will, I should have declared this at the beginning.
It's okay.
I'm a member of the University of Suffolk board and their partner in the creation of this joint venture, if that's the right description of it. So I have that interest, which has potential conflict. So deal with it as you will. I'm happy to part the room if that helps.
If needed, Steve, I'm sure you would, but at the moment, declaration of interest declared and noted, I'm sure we'll manage that. Thank you very much. Richard?
Thank you, Chair. So we're bringing a short report basically just to give a briefing on the work that we've got underway around dental. I'll not rehearse the challenges that I think everyone's aware of in terms of access to dentistry across Suffolk and North East Essex, indeed across the country. That's set out in section 1 and into section 2. You'll see also, and it very much resonates with the earlier item on elective, the impact of those on waiting lists, not just on the specific condition, but on their wider life, socioeconomic factors, etc., and indeed how it's exacerbating inequalities, as you'll see in section 2. You may also be aware that from April 2023, all integrated care boards will be taking responsibility for dental commissioning alongside optometry and pharmacy. And I think we've got some fantastic opportunities, notwithstanding the challenges that we currently face, in actually taking that challenge on and improving access and the outcomes for our local population. So we've formed a dental task force that I'm privileged to be chairing, and involves a variety of partners, including Andy from Healthwatch, both universities, the region, our local dental committee and others. Excuse me. And through that, we've developed our own programme of work in advance of taking on the responsibility for commissioning. So actually starting to do things that we can do within our own gift as a set of partners locally. And section 3.1 takes you through some of the specific things that we've already got underway. So given time, Chair, I'll just talk about a couple and then talk about the University of Suffolk development. So you'll see section 3.1.1, we've actually about to announce an additional 20,000 check-up or appointments across Suffolk and North East Essex, provided by 8 of our local providers. I can't yet announce which ones because we're just at the tail end of that joint procurement with the region. We'll be announcing that shortly. So that's an incredible additional capacity that we've been making available into the system. We've also put in additional funding from the ICB to get our waiting list for domiciliary care dentistry down to 0 by the end of the financial year, and also reduce for specialist dentistry. So that's those with vulnerable children and adults with special needs, where we've got particular needs and waiting lists, a 45% reduction by the end of March. We'd like to go further, but that's the commitment we've made this year with the funding we've got. At the same time, we're in conversations with both of our public health departments around more of the preventative side of dentistry and oral health. Both oral health profiles have now been produced by our local public health departments, and it's demonstrating, as we expect, a significant need, particularly again related to our inequalities agenda. So we're looking at investing in a range of preventative measures with local schools across Suffolk and North East Essex in terms of toothbrushing, the Keep Smiling campaign that we have in Suffolk, and a similar exercise over in North East Essex, and a number of other things that we're hoping to put into place as soon as possible. I'm also pleased that we've done some specific work around looked after children with both local councils, and we've got a number of practices now we're making available specific appointments for children who are looked after to access dental care, which was a particular challenge for us. And then finally, as I said, just moving on then to what I think is quite an exciting partnership initiative that Ed alluded to at the start in his remarks, thinking more longer term, where we're in advanced conversations with the University of Suffolk and Health Education England and NHS England about a longer term partnership to develop dental training locally. So you'll see at section 3.1.13, we've already managed to get funding. I have to say, driven by Amanda and Ed, who have absolutely championed this over the last year with colleagues from the university, to the formation of a Centre for Dental Development, clinical simulation and treatment facilities, and the development of a dental community interest company. So we're starting to think differently and innovatively about how we can actually grow our own workforce. It links back to the training hub item we talked about earlier about how can we do more things locally, innovatively, and how can we potentially look at a different commissioning and funding model for this that moves away slightly from the national model. And as Ed said, we're really privileged to have the Chief Dental Officer on board in terms of her role in this initiative. So that's a bit of a whistle-stop tour, Chair. I'm happy, I'm sure colleagues as well who are more involved in the dental work with the university, happy to take questions.
Great, thank you, Richard. So, a lot of work in progress, still a lot to do though, but a plan is in place. Any comments, questions, or are we happy to receive and note and hopefully support the further work that is identified, and no doubt other actions will spring out as that develops, because that's the way life is. Everybody content? Received, noted, supported? Marvellous. Thank you very much. Thank you, Richard and team. In which case, moving on to item 14, the Suffolk and North East Essex ICS research paper. Now, Andrew tells me he's condensed several hundred pages here to 5 key points. So, Andrew.
I said about 5. Thank you, Chair. So, we know that patient outcomes are better if patients have the opportunity to take part in research, not just by the findings of that research, but by taking part in research itself. Outcomes get better, so it's an important thing for us to focus on as an ICS. This paper was very much prompted by the research report from ESNEFT, although when I looked further, I found there were similarly excellent research reports from other providers, and I'll just draw out some highlights from them, accepting they're probably read already. So within primary care, we've delivered research across 64 GP practices and 24 PCNs. Within mental health and our providers, approximately 2,000 patients have had access to research, albeit not all of them in SNE-ICS, but nevertheless it's a marker of highly effective research institutions. In ESNEFT, 260 studies have been conducted across 29 departments with approximately 5,000 patients having access to research, which is absolutely remarkable. On top of this, we have focused on inclusion in research, making sure that we're inclusive and that we don't drive health inequalities inadvertently through our research work. We've been developing new researchers across the system. Our providers have engaged with NHR and other local academic partners. And finally, we've been able to reinvest a portion of that research income back into clinical services, so a lot there to be proud of. We presented a research strategy here earlier on this year, which has been agreed, and on the back of that, as an ICB, we're developing a more detailed plan for how to improve upon some of those terrific outcomes already. But there are opportunities to improve the amount of research in primary care, to extend our research networks into the west of Suffolk, and to potentially extend our research into social care and social work as well. So there's opportunities out there, but a great place to build from. Shane Gordon's in the public part of this meeting today, and I'm sure he'll be happy to answer any questions on the ESNEFT report, and happy to take any more generally myself.
Wonderful. That's great, Andrew. Thank you very much. And some fantastic work described in the annual report. So thank you. Steve.
Yeah, Andrew, I sent you a brief email. I mean, given we've got two of the world's most important pharmaceutical companies in our region, and we've got some extraordinary organisations such as Cancer Research UK and wider, I just wonder what the more commercial and investment elements could be from this research strategy. In particular, the number of at-scale trials are shifting back more towards common chronic diseases of weathering, if you like, rather than the rare diseases. So it just would encourage you to kind of explore that a little bit more and just see, because I think places like Cambridge haven't got the typical population we've got here, and with our digital strategies, we are building huge amounts of data about where people live, how they lead their lives, and what the opportunities are and how we can track them lifelong. So just another string to the bow, I think, to perhaps think about.
Yeah, and we certainly have access to useful and representative populations, don't we? And with the research networks already in place, we're well placed to develop that sort of thing. And Caroline Angus, who's leading an innovation within the ICB, is already developing a commercial integration framework to make sure that we integrate with private companies effectively. So there's building blocks in place to do that.
And if we look at what Lord Drayson's done in Oxford, where effectively he's turned the population of Oxford into this kind of research-ready, data-enabled, digitally connected population, I'm sure we could play in that space too.
So it's a useful prompt. Thank you.
Yeah, good. Thank you, Steve. Any further questions or points? Otherwise, we're asked to receive and note, and indeed to share the information and reports in Andrew's paper. All agreed? Done. Thank you very much. In which case, item 15, the Cancer Transformation Programme. Richard?
Thank you, Chair. So this is a fairly short report which is actually asking for approval to the funding plan for the 22-23 Cancer Service Development Fund, so effectively the non-recurrent pot that we get each year from NHS England to further the cancer programme. The reason that I'm bringing it here today, it's above the sign-off limit for the Cancer Committee for particularly the ESNEFT element. So the sign-off limit is 1 million, it's just over at 1.2. Hence the reason for bringing it. Just in terms of background, you'll see at section 2.2 that there is an annual cancer programme at a national level. We have the Cancer Alliance that actually Nick is our esteemed chair across both cancer alliances locally. And then we've got our local programme within Suffolk and North East Essex. We've got a range of national initiatives that we need to respond to, and then we've got a local programme in place to enable that to happen. You'll see in terms of the governance that we've got the ICS Cancer Committee that meets on every 2 months that I chair, and then we've got a monthly operational group that's focused on the detail, and we've also got fortnightly meetings with the Cancer Alliance and the NHS England team. So there's a lot of focus not just on the programme but on the actual spend of the cancer programme budget itself. Section 4 gives you the specific details of what's been requested, and for the first time this year on 4.3, the national cancer funding splits it out specifically into those national priorities. So our local programme then reflects that, and as I said, we've then got the more detail, if any colleagues would like to see, offline that the Cancer Committee is then focusing on. So, as I said, it's approval for this year's SDF, and the Cancer Committee has got the oversight of that ongoing.
Thank you, Richard. And Howard?
Yeah, just to assure the board that the funding is in place, and no objections from me at all, so thank you.
Okay, thank you very much. Any questions, thoughts, any challenges? Are we taking this, therefore, straight to approval? Everybody happy to approve? Unanimous? Approved. Thank you very much. Item 16, the System Oversight Framework Performance Indicators. Paul, over to you.
Thank you. Chair, I've picked up the challenge, the succinctness So I'll try and cover 3 broad points on the report. So I think it is important for me to flag that the NHS operating framework has been published. I think from our point of view, it builds on the soft framework we discussed at the previous board. So again, it's an extension of that. But I think we need to start to understand that it starts to bring forward NHS digital, NHS education under one umbrella. So again, that is very much in progress. It very much talks about statutory duties remaining the same, but changing and influencing through behavioural changes. I think for me, the key point, though, is that it starts to drive and continues to drive the ICB toward earned autonomy and being the first line of holding systems to account, or local providers and to account in terms of performance and other elements. So again, very much part of a journey. We still need to understand the details that it works through, but I think it's quite an important point in performance terms. The second point, just to pull out of the paper, is we had clearly our first ICB review on the 3rd of November. The first meeting was very much sort of ICB executive and yourself as chair. I would characterize that as a really positive meeting. From what I've seen, there were very few directives that came out of the meeting, which is always a very positive position to be in. There was an absolute clear acknowledgement of the work that we're doing. We had clearly had challenges. We were at grip on the challenge we were doing, how we were dealing with those challenges that we're moving forward. I'm going to pause there a couple of seconds because as both Ed and yourself were here, maybe you might want to add a couple of comments before I move on.
It was great meeting. Yeah, it was well received and the team performed well. So, yeah.
Okay. Thank you. Significance of that meeting is that's how they will start to view us in terms of segmentation moving forward. So a very, very major part of that. In terms of performance, Ed's already alluded in his introduction that we received a couple of letters in terms of going further for winter. Fortunately, we are pretty much there in terms of the ask. However, there's always more that we can do, and in particular around dictate around respiratory hub construction, and we start to look at that element of what else we can do in terms of preparing further for the winter, which is likely to be an increasingly difficult season. We're also taking part of the national winter collaboratives and as a system in terms of focusing on some key elements. If I was to summarize broadly the performance, we still have significant risk around urgent care, in particular ambulance delays. The system is on tremendous amount of pressure, and I'm sure Nick and acute colleagues will acquiesce to the fact we've been on level 4 for some time and managed some very, very difficult positions with some clear risk in the system. We have developed an approach to supporting ambulance through what we call the stack, which is essentially putting patients off the waiting list that are waiting for an ambulance to try and deal with them with a system that's working really, really well in terms of reducing the amount of ambulance conveyancing that we're seeing, but we need to go further, I think, for alternative ways. We're pushing some of that. The final point I would make is, as part of the action at the beginning of the meeting, you've also got included within the summary of the soft KPIs, the actions that have been taken by each of the committees and some of the contextual backgrounds of the work plans that have been undertaken to support performance within your pack. So happy to stop there and pause and answer any questions. Thank you.
Thank you, Paul. Any questions for Paul? Otherwise... Oh, sorry, Ed, yes?
Just your thoughts, Paul. You heard the Cassius presentation earlier and how that could be brought into the winter plan, as it were, from your perspective.
So as an urgent care committee, I think we are conscious of that piece of work, and I would suggest that we bring it through the UCC and request the UCC start building up the case for it across the system and then bring it back to board once we decide how we're going to do it.
Okay. And Steve?
Yeah, I guess it's the question I've asked for, which is how are we different and what do we do differently? So we've got an operating framework, and I think I've only been a member of this board since April, but we seem to focus on assurance and compliance rather than strategic analysis of the gaps and the difference. And what does it mean we do differently in terms of setting direction, allocating resources, accountability, all the stuff through to delivering services, enabling improvement. So it's that kind of gap analysis, if you like, that with this new operating framework, do we need to strategically act in a different way? And what would the shared executives' views be that we as a board could get our teeth into that might enable some of the provider networks to grow, might have a different solution to workforce, to integration, devolution in place? And how do you engage us in that discussion in the future rather than the compliance and assurance model.
And just a suggestion, Paul, while you're turning that over in your mind, and do tell me if this doesn't make sense, might that be a development session discussion that could be usefully had? Over to you.
If I can come back, I think we have to go back to think about the governance structure we've put into place. So we have a number of dedicated accountable committees which report directly to this board and also provide assurance to SOAC. So I think if we're looking for out-of-the-box solution, we should be thinking and talking to those committees to say, so how else would you might achieve, what level of data analysis do you need, what alternative plans? So if you take ambulance services, for example, and you look at the model of care that we undertake, which is essentially everything goes to an ambulance service. We are starting to move very much towards a decentralized model of care where integrated care supports ambulance conveyancing. So is that signaling a different approach to the way and the model of care that we provide? I think those are the sort of questions we should be asking committees to think about and to bring back to this board.
And then how do we have a live discussion with the public, if you like, where we're making some hard decisions to help prioritise and shift the dial a bit.
So, Steve, would it work for you if what Paul described happens, if we then bring it to board in a development session so that we can have that discussion and then take it forward in the way, the next steps? Okay, thank you. Nick?
What was question or comment really? The question, it may be far too early, but I just think it's important that we're aware of it, is the announcement that Ed alluded to in his briefing about the appointment of Patricia Hewitt to lead on the debate between ICBs and region and where accountability and responsibility sits. So I think really encouraging Ed and all of us really, if we have the opportunity to influence that piece of work, I think is really important. I suppose the second thing was a comment, and it's interesting that the feedback from the regional meeting was quite positive, because if you just look at the numbers, that's quite difficult, isn't it? And again, I was talking to, it feels like we had a pre-meet, Ed and I, this morning. We didn't, but it just came up in our conversation. If we'd looked at these, whether it's as an organisation or as a system, at our performance against our constitutional standards 3 years ago, we wouldn't be sitting around the table, to be honest. And yet the bar has now been lowered to such an extent in terms of performance against patient experience particularly, that where do we sit as a board in terms of, if, I suppose putting it crudely, if the region are not going to hold us to account, and we're not feeling a bit twitched when we go into a regional meeting and we come out. And I know the reasons for that, because when you look across the east of England, we are performing well. Should we accept that we're not going into a regional meeting with our exercise book down the back of our trousers? And how do we raise the bar locally for the people that we serve? Realistically, because we're not going to be delivering 95% in ED, we're not going to be delivering 18 weeks or 62 days or access targets in other parts of the system anytime soon, whether it's mental health or anywhere else. But what do we do as a board? Do we wait for that meeting with region? Do we raise the bar? Do we set some standards that are challenging but achievable, and then hold ourselves and each other to account for that delivery? It's a bit like the conversation we had last time.
So, question really around ambition, isn't it? Let me go to Paul and then Ed for a comment.
Yeah,
so Paul.
just an observation. I certainly don't feel not under pressure to respond to performance when I attend regional meetings. I've lost count of the number of meetings I go on a weekly basis to talk about performance, particularly on urgent care and elective recovery. I think when my comment was it was a positively received, I think we were able to demonstrate we understood the risks that we had in the system. We understood the plans we were putting in place to try and address the issues, and we had a grip in terms of our next steps. And we had set some local ambitions, particularly around ambulance delays, particularly around 12-hour waits in A&E, etc. But I think your point is well made. Should we supersede that ambition as a board to decide how we'll focus on what are the key metrics or key performance measures we might want to focus as a board, which are paramount to everything else, which sort of leads into the national conversations going on at the moment is, are we trying to focus on too many things in one go? So I think your point is well made, but there is certainly a lot of pressure at the region and national to perform against certain key metrics.
So before I bring in Ed, let me bring in Steve.
Thanks, Will. I'm with Nick. I've worked in this kind of system in the past. I mean, it's a bit dated, so I accept it, and things have moved on. But all Paul described are the kind of things that just get the region off your back. Nick's absolutely right. If we want to do something for this population that we serve that is worthwhile, we should set some ambitions of our own. We should have some standards of our own. We should hold ourselves to account collectively for those, not worry about our chums at the region, because they'll worry about the two worst, not the rest of us. We don't want to be the two worst. Thankfully, we're not amongst the two worst, but that's all they can do. And we want to make sure we're improving, even if, because frankly, Nick's right, we're not playing in the Premier League, using a football analogy. We're sort of the best in the non-league teams with the performance we've got at the moment, generally speaking. That's a very simplistic and crude way of putting it, but we've got to substitute with the region. We don't actually, frankly, if we behave as if no region exists, because who knows, they might not.
Imploring further ambition. Ed?
All good points. Just firstly, to be really clear, in that regional meeting, in my couch introduction, I was talked about the things that have moved forward, but in the context of an overall deterioration in the last 3 years, and that we were very unhappy about it. So just to be really clear on the kind of way we framed it. I think I agree with everything that's said, because NHS England are looking at how well have we implemented the things they've asked us to do, rather than what are the big strategic opportunities in our system, our assets that we can build on. So that's how we're trying to construct this agenda, the Cassius Plus, the scale up around the training hub, the waiting well. And I think that's where Nick is absolutely right. We should be setting ambitions around our assets. Where can we go quicker, faster, be more strategic, as Steve is saying, rather than framing it in terms of how well are we responding to NHS England guidance, which I think is what a lot of systems would do.
Okay, so as a board, we're grateful to Paul for the report. Thank you, Paul, received and noted. We agree the future work in terms of strategic review and how that, and the work we're going to do to align as a board. But more importantly, I paraphrase here, I'm sure Joe will put it in better words in the minutes, but we're never going to be happy, in inverted commas, because we always want to do better. And that's our ambition. Now the question is then, how do we deal with that, and how we deliver over the months and years to come. So that's the piece of work we need to do. Everybody content and agreed? Happy? Lovely. Thanks very much, everybody. Thank you very much, Paul and colleagues. Item 17, the BAF for review and approval, but with some comments from Amanda.
Thank you very much indeed, Chair. So here we have our November Board Assurance Framework, and I think there are probably 5 key points that I just wanted to bring to our board's attention. Number 1, we have 20 current live risks that we are actively managing. Since we last met in September, we've actually added 3 new risks to our framework. We have a further conversation at the Executive Committee on the 5th of December, prior to the BAF being updated for onward presentation to the Audit Committee on the 15th of December. And on the 5th, the Executive Committee have started the conversation, but will be wanting to conclude that in addition to what we currently have today in front of us, are there any additional new risks that we've previously discussed that we need to now incorporate? For example, the cost of living as a system, so quantifying what that risk might be and concluding with if indeed we add it to our next iteration. And then the other risk that we will be concluding for potential inclusion is around the organisational change impact, given we are now an ICB and an ICP, along with obviously industrial action. So They are risks, conversations that are bubbling that we want to conclude on the 5th. That will be then updated and presented to the Audit Committee on the 15th of December. And as we discussed and heard last time, the current BAF framework is currently under redesign, and we are confident that we can present to the Audit Committee an updated version, which will then come to our board in January. In addition to the risks in front of us today, I just wanted to inform the board that internal audit have concluded one of 2 pieces of work. Phase 1 has just been concluded, and that's around, now that we're an ICB, what is our risk management process. So they've done that initial piece of work. We're still awaiting their report, but I believe the findings will be going to the Audit Committee in December. Phase 2 will then follow probably around February, and they'll be then looking at how we actually actively manage our risks as a board. So I just wanted to make colleagues aware of that. And then my final point, I think, before we open up for further questions is, we may have touched on this before, but I think it would be really healthy, now that we're an ICB, to really have a proper conversation on how we as a board actively manage our system risk. And I think we are no different to other systems as we are on this journey of BAF and the like, but I think that's something that I would want to commend to the board, perhaps something like February at a future board development session. So I leave it there, Chair, but very happy to take any questions.
Thanks, Amanda. Thank you for that. Let me go to Steve first and then Andrew.
Thanks, Bill. Thanks, Amanda. Just to reiterate, the Audit Committee did have a conversation about BAF and risk register a while ago. Amanda has reflected all of that in what she's just said. I think I'd just emphasise a bit, in addition to the business of focusing on some risks that we thought hadn't been fully explored in the risk register as we last saw it, there's also a question of us focusing the risks in a little more of a strategic context, more appropriate for this board. So that's the sort of work we're expected to see developed over the next little while. And I guess we're a bit early in the cycle today for that to have come through in what we've got in front of us.
And you're particularly thinking, are you, Steve, from a system point of view?
Well, Amanda made the point about the system, so absolutely yes. So the system, there were some specific risks around workforce, around economic development, integration, the impact that has on our capabilities and capacities. But then also, how does this sit in the kind of strategic, as opposed to the rather more operational sense in which we've currently got our risk register framed.
Okay, so more work to be done, more work to come. Andrew?
Actually, quite related to Steve's comment, given that one of the functions of our board assurance framework is to describe the risks towards meeting our strategic objectives, will there be an opportunity to review it once our strategy is completed at the end of the year, and actually use that as a springboard to develop what our overall approach to risk is?
Agreed. Yep. Noted. Patrick, yep.
I guess it highlights the complexity of the system we work in. So I was just looking down the list there, thinking where we have our functional risks within the council and where we have our strategic risks in the council, and where does that lead into this, and where are they or aren't they reflected in here? And I guess others around the room could do a similar thing. So there is something where we do need to be mindful that we are kind of taking that back to look at our own strategic risks as individual organisations, making sure as a system we're reflecting accurately that we are capturing. Because what you wouldn't want to do is a partner in the ICB has a risk that isn't declared on here, but actually then impacts on the ICB. So there is probably a takeaway action for me, just to make sure that our strategic risk is reflected in this and pick up outside if necessary.
So generalising Patrick's point, all system players to ensure that they are aligned, that they're, and actually where there isn't alignment, to flag that so that we know about it. Yep. Noted. Okay. Oh, Andy, yeah. Do you need a microphone, Andy? You may. Yes, you may.
Thanks. my first thought is that you're heading in the right direction around strategic risk management as an ICB. But if I think back to what Nick's just been saying, I wonder whether or not we should also have a strategic opportunities log. Because if we're only looking at standing on the back foot, surely we should also be looking at what we could be doing it actively to look at opportunities.
Yeah, good point. Well made. Thank you. And Nick's almost smiling at that suggestion. Are you... No, that's true. It's the pain in the foot. Yes, if you're in pain, I know.
I'm not sulking. I did need to...
Yeah, no. Yeah, he did tell me that he'd have to go at 11:30. So yeah. Okay. We'll let you slip out quietly there, Nick. Thank you very much. Okay, colleagues. So received, noted, work plan as outlined by Amanda. I won't go through it. Agreed. Good. Thank you very much. We'll take that as approved as is, in which case then item 18, Paul, procurement.
I'll be quick. There are no decisions to be made by this ICB. I think my team have treated you to a really long list of activities which won't be coming to this board in future, but it is really an attempt to demonstrate that the thorough work that is currently undergoing at the moment in terms of procurement-related activities. And in fact, when you look at the list, maybe 2 or 3 will ultimately come to this board for a decision based on procurement. But there is an important point here, I think, and it's because it needs to be seen in the context of the new provider regime legislation changes, which is currently making its way through the ASA laws at the moment, and hopefully to be in place by April 2023, if it's not delayed any further. Which essentially means that any transactions above 10,000 will have to be published and be able to be visible and have total transparency how the decisions have been made to allocate any funds, and that will be part very much of how we do business. So again, an important factor to understand that all those transactions will be captured in that way. In order to try and make some sense at ICB, we've recently agreed to go with a software called Atomis, which brings together all contracting functions under one software, which will enable us to have far greater clarity as an ICB, both in terms of spend, in terms of timelines, in terms of wants, and in terms of decision making. So we're currently scoping how quickly we can get that piece of software in place, which will enable all of the ICB committees and members to have access to the relevant information. And finally, the only other point to make is, given the fact that we are now moving as an ICB in terms of procurement, the team have been focusing on a number of things: training by committees and individuals and SROs, thinking very closely how we can engage with volunteer sector and the greener issues through the procurement route, and how we approach procurement as a selection process, and social value. So I'll stop there. It's a bit of a summary of the paper. Thank you.
Thanks, Paul, and I know you'll be happy to take any questions, but also you're asking for feedback on this paper, and I'm sure you're very happy to take that outside the meeting or electronically, if that's helpful for colleagues. So any questions for Paul? Howard?
Yeah, first of all, I really welcome the approach that you're taking in terms of building greater sort of rigor around some of the processes. I was just struck by the number of procurements. I counted about 30, and also just that's an operational question, I suppose, but linking back to the other discussions we've been having around strategy, but how are we linking these procurements into our overarching strategy, and maybe there's a bit of work to be done around doing that.
Yeah, so just to respond, I tried to use my words carefully. I said procurement-related activity. So when you look at a procurement activity, it's something as simple as single waiver. So you might want to spend 20,000, but there's actually a real reason why you go straight and make a decision. The issue, and as part of the process, you have to capture that decision making, make sure you can look back and justify that decision. So there are a huge number of proper procurement, but there are lots of decisions that relate to procurement, and part of the software and part of the education program is to make sure that we always understand and make a conscious decision how we make decision on spend and procurement of services, and that'll be very much flowing through committee structures. Does that help?
I can see that Howard's not totally happy, but might that be something that you'd like to pick up outside the meeting? Could, that sounds like a debate worth having for sure, but perhaps we're time limited now. Are you happy with that, Howard? Yep. Okay, thank you very much. Any other questions for Paul? Otherwise, received and noted, and then electronic feedback or feedback outside the meeting direct to Paul as requested. Okay, thanks very much, colleagues, in which case item 19, the Chair and Chief Executive action on specialised services. Are we going to you, Richard, for this one?
Yeah, that's fine. Thank you, Chair. So this is just to endorse a decision that Ed and Will made, given the timeframes that we had to respond to NHS England. So this relates to specialised commissioning, which is another area of commissioning responsibility, which ICBs are being asked to take on. The original date proposed at a national level was April 2023. We had to go through a process using effectively a form to set out in each of our 6 ICBs that make up the East of England, working with the regional specialised commissioning team, our case effectively to take that on. There was a recommendation following a number of meetings between the 6 leads for this, including myself, and then endorsed by the chief execs, that actually more time was needed to enable us to get this right. So the recommendation that all 6 ICBs came to and then was endorsed through the regional leadership team of NHS England was to delay till April 2024. And in the interim, you'll see there that there is a joint specialised commissioning committee that has got representation from each of the 6 ICBs on it. I think 2 of the main reasons for the delay, firstly, is the financial position is still needs significant more work at a national, regional and local level to truly understand what each ICB is being asked to take on. And secondly, the final list of specific services that are commissioned by specialised commissioning was also not finalised in time. So we collectively felt, endorsed by the region, that we were running out of time to enable us to do this. Indeed, across the country, there are very few areas that are actually going to be taking this on from April 2023. The majority of the country will be going with April 2024.
Yeah. Noted, and good points well made, Richard. We're asked to endorse the action taken by Ed and myself, which obviously we've got an interest in. Steve?
I'm happy to endorse the rate, but just a point of clarification. Who carries the risk in 23-24 if specialised commissioning spends more than was initially intended?
The region. So the region's still got NHSE, full accountability and responsibility. Yes.
Stays regional.
Correct. Till April 24, which
but
is when
regional means NHSE national, not the 6 ICBs in concert.
So the accountability line still sits. So it's a joint committee, so we will be sitting on it next year, but the accountability for commissioning remains with NHS England. National for some things, region for others. And again, they're still in debate about what things could come down and be done locally and what sticks
the reason
nationally.
I asked to push that is that there's no body called NHS region.
No.
It's either NHS
England,
us, isn't it?
Through region.
And I just want to make sure we're not talking about some common committee in common, which means we get 1/6 or 1/8
that it bounces back to us, yeah. But
it goes upstairs.
Richard's assurance is that it goes up.
It's going upstairs, to use that analogy, to Amanda Pritchard and team ultimately still for accountability.
Marvellous.
But only for next year.
But only for next year, yeah, understood. Noted, endorsed. Great, thank you very much, Richard. In which case then, Executive Committee Terms of Reference, Amanda, I wonder if we could take this straight to questions, do you think?
Very happy to, Chair.
You're happy to, that's great. Okay, so any questions for Amanda? Steve?
Yeah, I think I lived slightly in the past, but when I was in your position, I saw my role as chair of an executive committee as having the role and responsibility to execute the strategy as set by the board or NHS England within the resources available to me at best value to the taxpayer to achieve the greatest possible outcome. And I just wonder if a way of encouraging a more dynamic tension between the board and the executive in terms of using the board to help deliver the strategic oversight and framework within which you can be more efficient and effective in your duties as an executive committee would be to more firmly link that your role is to deliver the executive actions that bring to life the strategy as determined by the board and NHS England. And the second thing that's a bit light for me in here is, and within the resources available, for the accountability around the resources and the finances, because I don't see a specific. Now, Ed, I'm very happy to take that offline, but it just, I just wonder if that's just the missing link between the operational, bringing a lot of operational stuff and whatever, versus actually as an exec sitting there and thinking, what do we need these guys to do to give us the air cover, the different direction, make some decisions. I mentioned provider networks quite often. What do you need? What are the conversations here that enable you as an executive to execute at best value to the taxpayer and within?
Thanks, Steve. Could I make a suggestion here, Steve, Amanda, and indeed Ed, see if this works for you? Would it be acceptable to accept the paper as a working draft?
Yes, I'm very happy to accept it. I'm just looking forward, I think.
Agreed as a working document for today, but the development thereof, perhaps, bearing in mind Steve's comments, if there are amendments, to come to back to a future board. Are you happy with that?
Next revision or review, but
Yep. Happy with that? Yep.
Really helpful. Thank you, Steve.
Okay. Noted and agreed. Approved. Thank you very much. Item 21, declarations of interest, etc. Amanda, back to you.
Thank you very much, Chair. So we will have this report as a board twice a year, and it basically gives us an opportunity to look at our entire declaration of interest register alongside the gift and hospitality. So it will be presented twice a year, October and April. And we, as a board, need to consider, are we content with the information that has been provided? And indeed, is there any additional action that we are required to take or should undertake prior to it then be publishing or being published on our ICS website? So today it's here for us to consider, are we content with the information provided, or are we wanting further work to be done prior to the publishing?
Okay, thank you. Comments, questions? Are we content, as Amanda has asked, to move to publication? Amanda, I think the answer to that is yes. Any more from you, or done?
I think I just wanted to make a quick point, Chair, if I may, that
Please.
In terms of a number of reds, if you like, I think there may be an action that you may wish me to undertake, and that is to follow up with the respective director colleagues to ensure that we get better compliance in terms of registers of interest returned.
So the ongoing reds to be, I think they've already been chased up twice, if I'm not mistaken, so to be chased up a third time with board emphasis on the importance of de-redding those reds.
Thank you.
And with perhaps CC to divisional directors to ensure that that happens.
Thank you very
Content? Steve?
Just a small point. A small point about consistency. Generally, it's fine, but I note that some of our members who have what I call ex officio status here, Nick, for example, identifies his role as CEO at the Trust. He's here because he's CEO of the Trust. And yet, other people who are here by virtue of their office haven't got the same kind of things. Now, it doesn't matter much, but maybe a bit of consistency there.
Consistency.
For those persons who are here because of their office, that's a naturally understood conflict, potential conflict.
Yeah, and this has got to be contextualised correctly in the sense that members are not representative, but in a unitary board. So with that in mind, consistency, but noting the potential conflict.
Whichever way, as long as we just need to be, I think we're currently inconsistent in the way that those things are declared.
Okay. Happy with that, Amanda? Noted? Good. Approved to publish as amended and to take the necessary steps. I mean, this is inevitably, inexorably a live document, isn't it? Okay. Good. Thanks very much, everybody. Then, Amanda, I'm staying with you for 22 amendments to the ICB Constitution.
Thank you very much, Chair. So this is really a technical adjustment that we were required to make to our constitution, which we've previously seen as a board. And conversations and more have taken place with the Chair and Chief Executive through NHS England. And we are required to, under section 2 actually, key issues, identify where those technical adjustments are and indeed what's been amended to ensure that we are up to date. So I would underscore the word technical, and that's really the only change to our constitution which we've previously approved.
Thanks, Amanda. Any questions or points, or are we happy to endorse as requested? I see no hands raised, so endorsed. Everybody agreed? Lovely. Thanks very much. In which case then, let's move on to item 3, the committee reports, minutes and so on. Perhaps I could just whiz very quickly down that list and ask the responsible individuals if there is anything they'd like to comment on by exception. So you don't have to have a comment, but the opportunity so to do, and then we'll see if there are any questions. So first of all, Audit Committee, Steve, anything you'd like to add to the minutes?
Nothing to add, thank you, Chair.
Lovely, thanks. Any questions for Steve? No. Received and noted. Remuneration, no meeting since the last board, Tanya, so nothing to say? No. Quality Committee, Steve, minutes of the meeting.
Just to say that I've got a meeting with Lisa and Andrew after this, because I think the Kirkup report into Kent, compassion fatigue, workforce and some of the quality failings there is likely to be a systemic issue across the country, and that is something we may need to bring to the board in the near future.
Okay, thank you very much. Any questions for Steve? No. Finance Committee's not met and reported. People Committee, Tanya, anything you'd like to say?
Ed kindly chaired that for me, so I don't think there's anything extra. Just the workforce conversations are live between Amanda and I about industrial action, so we'll keep you updated.
Okay, and let me bring in Howard.
Yeah, sorry, just to go back to the Finance Committee, because it's not been set up yet, because we're waiting to establish to establish the chair, but hopefully we have a plan in place to get it going in December, January, okay.
Okay, noted, yeah. Thanks for that, Howard, for clarification. And any questions for Tanya or indeed Ed on People Committee? And then People and Communities Committee highlight report. Lisa, anything you'd like to flag? You don't have to. No? Any questions for Lisa? Noted. Estates Committee. Now, we don't have Paul Fenton here, do we? But any comments or questions on the Estates Committee paper? No. Received and noted. The Strategic Digital Investment and Assurance Board. Andrew stroke Ed, anything you'd like to say? No? No. Any questions? Received and noted. Thanks. And then Procurement Committee.
If I may suggest, Chair, we took a decision at last board that we would not establish a Procurement Committee. We would keep it under watchful waiting, should we say. So I would suggest that we don't put it onto the documents, so we don't keep having the same conversation until we think we need it, in which case we'll bring it back.
So we'll note for today that the existence of said committee remains under review, and until that decision on that's made, we'll remove. Yeah, okay. Any other questions for any report at all? Otherwise, we'll take as received and noted. Attendance log, item 24. No, any questions? Otherwise, received and noted. Done. Any other business? None has been raised with me. Any, looking around the table now, let me see. Don't see any hands raised. No. Date and time of next meeting, 24th of January 2023. Wow. Time moves on, doesn't it? Item 27, questions from the public. I'm going to go to Simon first. Over to you, Simon.
Thanks, Will. So we have 2 questions that have been received in advance and one that has been received during the meeting through the live stream. So I'll go to the pre-received questions, both of which come from Anthony Dooley, the Secretary, Suffolk Unite Community Group. So he has posted the following question. I've read reports that the government is planning to offer a national contract to Palantir to handle patients' NHS data, and this will be done without any consultation with, let alone approval of, the public. Does the ICB, on behalf of the residents in East and West Suffolk and North East Essex, condone this use of public money without the engagement of those who will be affected, particularly given what Anthony Dooley has described as the known dubious practices of that American company? Will the ICB not cooperate with this and thereby put the interests of people before profit? Patients like me have already rejected a similar proposal to access patient data without our agreement a couple of years ago. We had to opt out in what should have been a situation where people can make up their own minds and opt in if they foolishly wish to. That's the question.
Let me go to Ed for a response to that. Simon, over to you, Ed.
Thank you. Obviously, this is a national government contract, so if it's okay, we'll liaise with NHS England on an appropriate response to Mr. Dooley's question.
Okay, thank you very much. And Simon, back to you.
Okay, the second question from Anthony Dooley. I've read that the ICS is planning to hold a people and community public event in Ipswich in December in the Town Hall. Could you provide me with more details about this and point me in the direction of where in the public domain this information can be found? I assume that this is going to be co-produced, is it? Perhaps Ed could confirm regarding the latter question.
I'll go back to Ed, or I see Maddie's smiling and maybe help out here. Over to you, Ed, first.
So I think it's an event on the 14th of December. It's advertised on the Let's Talk SNE website. It is going to be co-produced on the day. We'll email Mr. Dooley with all the details so he can attend if he chooses to do so.
Ah, great. Did you want to add anything, Maddie? Is that complete?
Exactly it, thank you.
Lovely. Back to you, Simon.
Okay, and the third and final question that's been received during the meeting via YouTube. Are there any training opportunities around adults who are autistic or information for social prescribers on what is out there?
Interesting one. Let me go to Lisa.
Thank you. Great question. So next year we will be rolling out the Oliver McGowan training across health partners, which is training that will be mandatory for all health, and it is around how do we better support people with a learning disability and people with autism. The training will be delivered face-to-face for the majority of people who have face-to-face interaction with people with learning disability and or autism, and will be delivered by experts, by experienced people with learning disability and autism. So that training is rolled out next year. I think the second question around social prescribers knowing where to signal people to, signpost people to, is a really good question. So I'm going to take that as an action, if I may, and just have a look at what information we give to social prescribers. Thank you.
Lovely. Thanks, Lisa. Thank you. Simon, is that it?
That is it. Thank you.
Wonderful. Okay. Everybody, well done. I've got it down. Oh, one yes, question. Yeah, sure. Introduce yourself first, though, for the record. Do you want the microphone as well? That is coming. That's it. Yeah. So.
Good morning. I met some of you last, 2 months ago, I believe, in
September.
Colchester.
Yeah.
That was exciting.
Just introduce yourself, though. It's coming through clearly. You're okay.
My name is Michael Nimi. I'm a member of a PPG in Felixstowe. The question I put to you 2 months ago was basically the civil money that is collected on new developments is there to provide the services that an incoming or growing population will make upon the existing services that are there to look after the existing community. The question I asked was, my medical centre had made application to NHS, the NHS, which part of it I'm unsure, there are so many of them, but apparently it was knocked back from a point of view of the expansion. The medical centre was going to require to deliver an appropriate service to the growing population that they expected would be coming to them. As of leaving home this morning, I received no response from this board on that particular matter. But in the interim, I'd been to see the senior doctor within that practice, and he said that in his meeting with this particular NHS organisation, he was told that the SIL money that is specific to a particular area, higher and lower depending on what services are already available, was actually not necessarily going to be used in our area. And I think what astounded me and him was the fact that the response was that this money could be used to keep the roof and ceilings on in the hospital at King's Lynn. Now, I know King's Lynn needs help. One would assume that is a national problem. But the SIL money, and I would like some assurance on this, is surely specific to the geographical area that the developments are going ahead. And across this county and many others, there's a huge amount of cramming and building going on. And the facilities to provide education, health, and the rest doesn't seem to be appropriate. So Maddie has a letter, I understand, that is there for me to take, and I might bring this back to you on the 24th of January 2023. But it is of great concern to me that we have massive developments underway. The money that they're supposed to be contributing to keep the services that are appropriate to them being provided
locally
isn't happening.
Yeah, and your
so
point
that was
locally.
the point. And I was hoping to, to progress this further with this board today.
No, good points. Right. Well made. Let me go to Maddie.
Yes, thank you. And I apologise to you, and as I noted at the start of the meeting, that we haven't had the contact that we should have had. But I'm looking forward to meeting you next week with the advice of our estates colleagues, and hope that we can understand further and look at the actions that we might need to take in Felixstowe.
Okay. Thank you. Okay. Thank you very much. So with that, everybody, let me just recheck the time. Well, 7 minutes to 12, and we were supposed to be finishing at 12. So what should we do for 7 minutes? Shall we close and say thank you very much to everybody who's contributed today, not all of whom are in the room with us now, I realise, but I know that we're grateful for the input from everybody as well as colleagues here today. Thanks very much, everybody. Meeting closed. See you in January. Thank you. Thank you.